I can hear you, so we can start. All right. Thank you. Yes. Thank you. Distinguished Chairman, Board of Trustees, management, and members of People's Expertise and Excellence Foundation, Your Excellencies, Your Royal Majesties, Your Royal Highnesses, all distinguished delegates at this conference, good morning, good afternoon, and good evening, depending on where you are. I am Dr.
Dr. Shabu, can you click on your screen?
PEEF is a non-profit organization which aims to improve the quality of human capital and its positive impact on the people in Nigeria and Africa at large. PEEF's membership comprises subject matter experts across the value chain of the economy. The theme for this conference this year is Universal Health Coverage, National Health Insurance Act, the prospects and challenges. This theme promises to be as challenging as themes of the previous 5 conferences organized by PEEF. This year, to do justice to this theme, we have lined up 6 key speakers as shown on the screen. These include Dr. Ngozi Nwosu, who will be sitting in for the Director and CEO of the National Primary Healthcare Development Agency, Dr. Faisal Shaibu, Dr. Charles Kojo, the CMD of Chesel Hospital, Kaduna, Dr. Mike Egbo, the Country Director of Genomics International, Abuja, Chief Mrs. Mojima Konjola, Dr. Patrick Korie, and Dr. Gafar Alawode. The ground rules for this conference are as follows. 1, that each of the papers will take a maximum of 20 minutes with another 10 minutes for questions and answers. In the course of the discussions, presentations, all mics shall be muted to prevent interference. We advise that delegates raise their hands electronically during question and answer and make brief contributions when invited to speak. Delegates may also use the chat box to post comments and questions to the speaker, which the moderator can track. The 6 papers will run serially, non-stop. However, we'll advise that delegates do not sit throughout the almost 4 hours of this conference. Rather, we advise that you should take some time to have some stretch within your area of comfort. Our rapporteur for this conference are Mrs. Jacqueline Money of the Delta State Internal Revenue Service, Warri, and Mr. Yusuf Umar of HB Concepts, Bauchi in Nigeria. Ladies and gentlemen, the chairman of the BOT, Engineer Abdullah
Can you support us, please?
Yes, beauty chair.
Yeah.
We're trying to, yes, please do. Your speech will be on the screen, and we'll also spotlight you, sir.
Yeah, but okay.
Dr. Shaibu, please stop sharing your screen. I'm trying to share the beauty chairman's speech. So stop sharing your screen so that we can share his speech as well.
Thank you very much, Chairman of the Conference Planning Committee, and thank you, IT. To make it faster, I would like to stand on all the protocols already executed by the Chairman of the Conference Planning Committee. So can you move down a little bit more? I thank the Almighty God for giving me the opportunity and the pleasure to welcome you all to this occasion. My distinguished speakers, moderators, participants, and also all the members of PEEF. I formally welcome you all to this 6th conference with the theme, Universal Health Coverage in Nigeria, NHIA, the prospects and the challenges. We consider this a massive undertaking for our country, for any country, and it requires policies and institutions and strong delivery systems with adequate metrics to enable successful coverage of our huge population, which resides in all nooks and corners of the country. Regrettably, we are also holding this conference virtually because we're still expecting the scourge of COVID-19, which though very much diminished, is still very much with us. As has been said, our organization, the People's Expertise and Excellence Foundation, is a body of professionals from all walks of life, largely Nigerians, locally based on the diaspora, and friends of Nigeria from all over the world. Our main objective is developing skills for excellence. Our vision, values, and motto are all available at the end of this conference, and I welcome people who have not been familiar with it to please visit our site and see what it is that we're trying to do. This event, as has been said, is the 6th PEEF Annual Conference, and is targeting again this very key issue of national importance, addressing the key aspect of human health coverage and addressing, we hope, in this thing, to galvanize action that will ensure effective and tangible achievements in improving the health system and upgrading the quality of life of all strata of society. We have previously held 5 conferences which address topical issues of great relevance to our national development and provided valuable inputs to policymakers and executors in our quest for excellence. The first conference in 2017 was Safety in the Workplace. The second one on education versus reality was trying to show how we can bridge the gap between education system and the real world and make sure that what people learn is useful to society and not just to themselves. And then we had again universal health coverage in Nigeria, challenges and expectations way back in 2019. And then in 2020, we held one on strategic leadership for economic rejuvenation to make sure that the downturn caused by the COVID scourge, as well as other economic wars, could be defeated and we get back to developing and improving the quality of life for our people. And last year, we held one on readiness for development of the African economy, which dovetails into the one of 1920 to make sure that now that Nigeria has signed as a member of the African Economic Community, we also are ready to play our roles and do things correctly that will improve our stances. Communiques from these were well received, and they're at various stages of incorporation implementation. So the theme for each conference usually selected after intense and now discussion as to its relevance to our social needs and our ability to make swift progress to enable us to start delivering benefits in a very short time. As you can see, today's theme is the second health theme topic in the conference listing above, which shows how much importance we pay to this very dear aspect of our national life. In addition to the above formal conferences, we have held what we call PEEF virtual talks regularly, 2 or 3 times a year, approximately quarterly, with excellent speakers on various topics that cut across all fields of human enterprise, from health, from education, from farming, human resources development, and housing. Again, please visit our website to get acquainted with the topics and what was discussed and how you will be, how they will be applied, and you will be amply rewarded. With regard to today's topic, please let us consider the situation of our country. A country of some 200 million people, a huge talented pool of skills and natural resources and endowments, a huge expectation from the populace that we can translate our assets and infrastructure and enterprise into tangible social construct that will enable us to provide a good quality of life for the average person. Among the long list of conflicting or sometimes complementary needs is that of sustenance of life. So the provision of adequate health coverage to care for everyone at all stages of life and in a healthy environment is a major issue in providing a sustainable social setting. governments at all levels, as well as legislators, have attempted to improve the condition and to let it, so that to make it easier to achieve a faster rate, some of the objectives of this conference. The theme has attracted the constellation of excellent speakers and session moderators from the Senate, from Ministry of Health, from the academia, from private practice, health management service, and services providers, as well as the media and other interested public organizations. With such a star-studded cast, I'm sure we'll have an excellent exchange of ideas from which will emerge clearer avenues to enable us to achieve sustainable goals in providing universal health coverage for all Nigerians at an affordable cost. I believe it is possible, and I believe we have the capacity to see this achieved in a short time. And this will bring the much desired massive increase in the quality of life for all Nigerians. At this stage, I welcome you once more to this event on behalf of my colleagues in the BOT of the PEP, and seek for your listening and full participation of what will be presented for review and contribution from all the participants. I thank the Conference Planning Committee, Chairman and his members, and members of the Foundation, the Secretariat, for working tirelessly to make this a success, ensure that we are all connected wherever we are in the world. Also, my thanks to the whole Secretary for the Foundation for his tireless efforts to make every event a success. So please participate fully in this event with all your mind, listen to our distinguished speakers and moderators, help us deliver a universal health coverage system for our country, which will be a model for others to emulate. So it is my pleasure to formally declare open the 6th PEEF Annual Conference. Thank you very much, and God bless you. Thank you, Chairman of the Planning Committee. I hand over to you.
Dr. Musa Rabiu, you may have to take over.
Okay, thank you very much, our distinguished Chairman, BOT. So once we expect the Chairman of the Planning Committee to come back, we would like to appreciate you for this excellent welcome address and for declaring open the next item on the agenda is a goodwill message by Professor Muhammad Nasir Sambo, the Chief Executive Officer of the National Health Insurance Authority. He's ably represented here by one of his GMs, Dr. Ike. Can we have Dr. Ike?
Hello? Hello? Hello?
Hello, Dr. Ike.
Yeah. Yeah. Good morning, all.
Okay. Good morning, Dr. Jonathan
Yeah.
Ike.
So sorry, I was having some little challenge with getting in. Yeah.
Okay. The goodwill message now from the
Yeah.
Professor Sambo. Yeah.
Yeah, thank you very much. I would like to, on behalf of Professor M.S. Sambo, who is unavoidably not around, make this goodwill message at the 6th People Expertise and Excellence Foundation, PEEF Annual Conference, which we are holding today. And permit me to stand on the protocols that have been set, and to state that it is my pleasure to be invited as a guest of honor to deliver the goodwill message at the 6th People Expertise and Excellence Foundation Annual Conference, holding today on the 27th of October 2022. I commend the organizers of the event, the PEEF, which is a non-profit organization focused towards addressing skill management challenges in Nigeria and across the African continent, for consistently organizing this event every year since 2017. In 2019, the National Health Insurance Authority, then scheme, delivered a presentation at the 3rd PEEF conference, explaining the theme for that year, universal health coverage in Nigeria, challenges and expectations. We talked about the challenges of both the demand and supply side, focusing on the poor state of primary healthcare facilities, the need for mandatory participation in health insurance, as well as the challenges of how to identify and pay for vulnerable populations. Since that event, over the last 3 years, there have been a lot of reforms within the health sector, especially within the health insurance ecosystem, towards improving access to quality healthcare for all Nigerians, which is universal health coverage. Many of the reforms within the National Health Insurance Authority are anchored on the 3-point rebranding agenda, which we call value reorientation, engendering transparency and accountability in the way we do our things, and accelerating the drive towards universal health coverage, which is the theme of what we are talking today. These reforms, like what we have done over these years, we've been able to develop a 10-year strategic plan, which we never had before. We have developed a coordinating framework for health insurance stakeholders, especially with the state health insurance agency. This will realize that it is not possible to sit in Abuja and achieve universal health coverage without bringing the subnational structures to join in the pursuit of universal health coverage. But even at this, it requires that there should be coordination so that we'll be working towards one goal. So we've been able to develop this coordinating framework, which we call health insurance, under one roof. We have also developed what we call the group, individual and family social health insurance, GIFSHIP, which currently covers all seven core members, several retirees, a lot of constituents of some of our representatives in the National Assembly, individuals and groups. And we think that with this program, we should be able to reach those people that were not originally capped within the structuring of the previous NHIAs. We have developed what we call the National Health Insurance Authority Medicine Supply Initiative, which covers the branding, cost sharing, and innovative financing to improve the availability, the affordability, the accessibility, and quality of medicines that we use within the ecosystem. And finally, We are trying to digitize the processes that we do in the NHIA system by what we call the NHIS project, which is automating all our business processes and linking all stakeholders within the health insurance ecosystem. So today, we are here to discuss the theme of this conference, which is Universal Health Coverage in Nigeria, National Health Insurance Authority, Prospects and Challenges. This focus on universal health coverage for the second time within 5 years is not surprising because ill health is often an unplanned event, which has the potential to push individuals and their families further into poverty. And our country is in an epidemiologic transition, characterized by a triple burden of disease: endemic infectious diseases like malaria, frequent epidemics of infectious diseases like Lassa fever and meningitis, as well as the rising prevalence of non-communicable diseases. Therefore, illness and ill health is all around us. Due to the economic recession, many Nigerians are struggling to pay for basic needs such as food and shelter, let alone pay for healthcare. When we look at the Lancet Nigerian Commission, we say that at least 83 million Nigerians, what about 40.1% of our population, do not have the financial means to pay for healthcare services. And a recommendation of the commission was that the government should find a way to pay for them. Even those of us who are relatively rich and can afford to pay for healthcare are still at risk, as we are all just one unfortunate illness away from poverty-inducing illness bills or catastrophic health expenditure. This tells us the importance of health insurance. The same way we require insurance for accidents and other unforeseen events is the same way we require health insurance for financial risk protection against illness. The signing of the National Health Insurance Authority Act into law by Mr. President on May 19, 2022 addresses some of the challenges we talked about earlier. The Act provides for mandatory social health insurance with private health insurance offered by health maintenance organizations to be on supplementary top-up basis. The implication of mandatory social health insurance is greater pooling of resources, greater cross-subsidy across risk pools, and improved equity in access to healthcare. The Act also clearly states the roles of the National Health Insurance Authority as a promoter, a regulator, and integrator of all health insurance schemes in Nigeria, while recognizing the roles of the state health insurance authorities and implementation of the basic healthcare provision fund as in our pursuit towards universal health coverage. One other important thing that the Act has put in place is the establishment of what we call the Vulnerable Groups Fund, which is to deepen what the basic healthcare provision fund is already doing. And some of the sources for the Vulnerable Group Fund include the basic healthcare provision fund, health insurance levy, and other sources of funding. The Vulnerable Groups Fund gives hope to the 83 million vulnerable persons who cannot currently afford financial access to healthcare, according to the Lancet Commission. Since the signing of the Act, we have met with various stakeholders to deepen their understanding of the Act, and we have kickstarted the process of developing our operational guidelines. Other activities are ongoing, including planning for the launch of the NHIA project and a proposed National Health Insurance Summit. Our goal is to ensure financial access to quality healthcare for all Nigerians. And I can assure you that we will not rest until the National Health Insurance Authority becomes a priority for all Nigerians. I thank you all for listening, and I wish you fruitful deliberations and a successful conference. Thank you very much. Thank you.
Thank you very much, Dr. Jonathan Ike, on behalf of Professor Mohammed Nasir Sambo, for that excellent, goodwill message, very detailed. We need to have a copy of that presentation so that the key messages that you have shared with us, we can look at them, critically as we go through the deliberations of the themes, sub-themes of this conference. So once again, thank you very much, Dr. Eke, for the goodwill message.
Thank you very
Thank
much.
you.
I'll send it over to you, sir. Thank you.
Okay, please do. Hopefully before the end of the conference duration today. Thank you. Thank you. Dr. Shaibu?
Yes. Sorry for when I needed connectivity most, it failed. Yes, thank you very much, Dr. Eke, and thank you, ES, for holding on while I was briefly away. I think after that goodwill message, we'll now take the first paper, and I'd like to call on Professor Ibrahim, Professor of Pediatrics at Bayero University, Kano, who is the moderator, to take charge of this session.
Okay, Dr. Shaibu, unless Professor Muta Ibrahim has joined, I think he's not yet with us. So Dr. Charles Kujo has agreed to be the moderator for this session. So I think yeah. So Dr. Charles is going to be the moderator.
All right. Oh, thank you very much. Dr. Charles Kujo, the moderator for this session, and please, I yield the floor to you, sir.
Yes, sir. Good morning, everybody. The next session from the program after the goodwill message is to be the keynote speech on universal health coverage in Nigeria, prospects and challenges. And here, this was to be Dr. Oh, sorry.
Yes.
We're moving on to, sorry.
Yes.
The role of primary health care in universal health coverage. And this will be delivered to us on behalf of Dr. Faisal Shuaib. I think his representative is standing by to speak to us.
Yes, the representative is Dr. Ngozi Nwosu, who is standing by to speak to us.
So, Dr. Ngozi Nwosu, I yield the microphone to you, please. You're welcome and good morning.
Good morning, Prof. And thank you for inviting NPACDA to this event. Please permit me to share my screen.
Yes, you can. Please go ahead.
Once more, thank you for inviting me. My name is Dr. Ngozi Nwosu. I'm the Director of the Primary Healthcare Systems Development of NPACDA, and I'm here to represent.
Please on presentation mode. The slide on the presentation mode.
Is presentation mode?
If you click at the bottom, that
it is
glass
on
symbol.
presentation mode.
Okay, maybe it's coming. All right, go ahead, please. Go ahead.
So I speak on behalf of my Executive Director, Chief Executive, Dr. Shuaib OON. So we give you greetings from the NPACD. Our role today is just to speak on primary health care in universal health coverage. The outline we'll be using to make the presentation. I'm mindful of time. So as an introduction, here is the country profile as according to the WHO Global Health Observatory. Nigeria is a country with over 200 million people with high levels of child and maternal mortality. We are a low to middle income country with a GDP of about $2,000 US per capita. The life expectancy in Nigeria is low, at an average of 54 years for both males and females. Low rates of financial protection, like the NHIA people have just told us, the out-of-pocket expenditure is quite high at over 70%, and government spending remains low at about 15%. Nigeria ranks about 42 on the Universal Health Coverage Index, with the world having an average of 66 and sub-Saharan Africa about 44. So here we have certain governance and policy structures that encourage primary care system, and this includes that the system recognizes that primary health care is the cornerstone of the health system, and as such, the health system has been organized to support it through agencies like our own, the NPACD at the national level, the state healthcare agencies or boards at the state levels, through national strategies like the National Strategic Health Development Plan with goals and objectives of primary healthcare, the National Health Act, as has been talked about, Basic Healthcare Provision Fund, and finally, the National Health Insurance Agency that has just been passed.
Sorry, Dr. Omosu, the screen is not, the slides are not moving. I think it's a general problem observed. So could you just maybe reshare again? Sorry about this.
Okay, I'll just.
It's not changing. Yeah, it's still on the cover slide. Yeah, it has moved now. Maybe if you put it on slideshow, it will be better. You can then move it at the bottom. Yeah, that glass, yes. If you click on that, then it will move quite easily. Thank you.
Is it now moving? I had clicked there.
But it needs to be on
Is it now
slideshow.
moving? It's on slideshow from this end. It's on slideshow from this end. Is it moving now? Hello,
it's not
moving now?
It's not moving and it's not on slideshow. You need to go back, double click on that particular title.
IT come. I don't know what is happening. It's moving from this end. It's on slideshow from this end. It's on slideshow. Are you seeing it?
No, it's not on slideshow.
Okay, I have sent the presentation to you. Can you try from there? Because apparently it's not moving from this end.
Okay.
It's on slideshow from this end, really. Are you seeing the screen now? Even though it's not on slideshow, we removed it from slideshow. Hello? Can you see the screen?
Yes, we can see the screen.
Is it on slideshow now?
It's not on slideshow on this side. I think the IT support can help us from their end if they have a copy of the presentation. IT support, please.
The latest version, the version I sent last night and this morning, that's what I'm using.
Yeah. Yes.
I think it's from their end. I'll reshare and see how it goes.
Okay, maybe can you
we're trying to share from here. Just hold on. We're trying to share from here.
Okay.
Is it on slideshow now?
No, it's not. Why, Dr. Ngozi, why not leave the IT support from ESN to share? They're trying to share the slide from their end.
Okay,
Yes.
I'll now stop sharing.
Yes, you stop sharing so that they can do
So
from their
stop
end.
sharing so that we can share.
I have
Stop
stopped.
sharing.
I have stopped sharing.
All right. Okay. Or can I attempt? Okay. Yes, can I try from this end?
Yeah, try from there because we're trying to get it out here.
Okay, let me try from this end. Okay. So can you see the slide?
No. Nothing
You
is showing.
can. Okay. What do I do?
Please, can you get that IT? Let them come and try from here. They've tried.
Oh, okay.
Oh,
2021.
okay.
Okay, here's the issue. We need to change some of the slides.
I stopped.
It's on editable format. So,
okay. Somebody has stopped me.
Okay.
Dr. Ngozi, you can start now. You can continue.
Okay.
Okay,
So
thank
go
you
to
very
slide
much.
what? Slide what? Slide 3?
Yes, slide 3.
Okay, continue
Summary of
then.
the country profile. Next slide, please. So like I said, we have a lot of governance structures and policy structures that support primary health care in Nigeria, like our health policy identifies national primary health care as the cornerstone of the health system. We have structures at the national level, like the NPA-CDA, at the state level, like the state primary health care boards, that also translate policies for primary health care into actions, as well as strategies like the National Strategic Health Plan, and also acts like the National Health Act. All of this support the delivery of primary health care in Nigeria. For funding, the Basic Healthcare Provision Fund through the National Health Act is also helps in making sure that primary health care is provided for the citizenry. Next slide, please. Our policy environment, like I have mentioned, the National Health Act, the National Strategic Development Plan, and also very essentially the Primary Health Care Under One Roof initiative, which tries to integrate all the PSC services under one authority, removing all the fragmentation and trying to increase efficiency in the primary healthcare system. We all know about the Basic Healthcare Provision Fund, that 50% goes through the National Health Insurance Act and 45% through the NPA-CDA. For the 45%, 20% is for provision of essential drugs, 15% for maintenance of facilities and equipment, while 10% goes to human resources. 5%, the remaining 5% is essentially for emergency medical treatment, including the newly established emergency ambulance service. Next slide. So the situation analysis in our health system, especially the primary healthcare. Next slide. Next slide, please. So the current situation is that we have very high maternal mortality, still at 502 per 100,000 live beds. You will recall that in 2018, the NPA-CDA established the NEMCHIC, the National Emergency Maternal and Child Health Intervention Center, and it was just aimed to reduce maternal mortality. We still have it quite high, according to the NDHS 2018. Under 5, mortality continues to be quite high at 132 per 1,000 live beds. Skilled bed attendance is just at 44%. Fertility rate is still very high, with our women delivering so many children. The bed cohort is over 6 million. And then, however, there is a lot of variation across the zones, with the northern zones, especially the Northeast, having the worst indices in the country. Between the rural and urban centers, there's also a lot of variation, with the urban areas having better indices than the rural areas. Next slide, please. Next slide. So what is universal health coverage? It's essentially just the right to health. Everyone, whether rich or poor, should get the benefit of getting health care without any financial suffering. And it means that there will be coverage of 100% for everybody in the citizenry, expanding the scope and the depth of services, making sure we reduce the cost of the financial risk, reducing the financial cost of getting help, which also means increasing the financial risk protection, and of course, increasing the quality of the services that we provide. Next slide, please. So it has many components, and it includes financial risk protection and affordability, making sure that we have equity or accessibility, the quality will be there and acceptable to the people, and making sure that these services are available to all and sundry. So if all these components are available, it will mean that we have high quality, people-centered and integrated interventions. Next slide, please. So the goals, where do we intend to get to with universal health coverage? We intend to have improved health, status and outcomes, financial risk protection for everybody, including the Nigerian women and children, and quality assurance and citizen satisfaction with whatever health services that we are able to provide. Next slide. So, where are these people that we intend to provide this universal health coverage? Essentially, it's the general population, including our women, children, adolescent girls, our pregnant women, and the under 5, particularly the poor and the vulnerable. And these people live in rural areas, hard to reach communities, urban slums, internally displaced camps, etc. And it covers all health conditions. But however, the main problem we have with reaching universal coverage as at now is the high out-of-pocket expenditure that we have. Over 70% of the cost of healthcare is out of pocket in Nigeria. And that is why we're very happy with what the National Health Insurance Agency is set to do in the health sector. Next slide. Next slide, please. So how is NPA-CDA and the country actually accelerating towards universal health coverage? We are doing this through 5 frameworks: financing, making sure that there is greater and better spending and more effective financial protection through the introduction of the National Health Act, like I had mentioned, use of innovative result-based financing approaches for efficient allocation of resources, improving health budget by analyzing the physical space and trying to source additional funding as much as possible, through people-centered services, making sure that we have better services, etc. And we are doing this through expanding the basic minimum package of services that we're able to deliver through the Basic Healthcare Fund, making sure that the PSC scorecards, which we do yearly, improves the quality of the services that we are able to deliver in the PSC space through rigorous assessment of the PSC systems of every state of the Federation across the state. We have just finished the scorecard 6, where we did this assessment, and the results will soon be out. And we also developed guidelines to strengthen the public-private partnership at the various state levels. In terms of equity, we are targeting the poor and marginalized and making sure that we leave no one behind. And that is why the one PSC per ward initiative is on, making sure that people living in very rural areas also have facilities to go to. We are strengthening both the outbreak response and pandemic preparedness, as well as emergency preparedness, by collaborating with our sister agencies. There's a lot of collaboration with the NCDC, with NAFDAC, with international NGOs. And in terms of governance, I had mentioned the primary healthcare under one roof initiative, which seeks to make sure that all the fragmentation is reduced. Instead of centralizing governance of PSCs, we are trying to make sure that we also hold them accountable and make sure that there is better coordination. And we're also trying to centralize the system, making sure that we are able to make sure that the financing is improved using the DFF approach that we use in our NSHIP approach, and also using the same for the Basic Healthcare Provision Fund. Next slide, please. So financing, like we know, is very strategic to achieving universal health coverage. So, so we are making sure that even though people are bypassing the PSCs and going to the secondary and tertiary facilities because of poor infrastructure, we are doing our best to make sure that we improve the infrastructure and bring the situation under control by making sure that we get human resources and other things to the PSC centers. We're also making sure that the poor funding, that we address it, and we are leveraging on the Basic Healthcare Provision Fund to revitalize at least one PSC per ward, and investing in primary healthcare systems to make it more resilient by also tapping into the private sector funding available. Next slide, please. So we have developed a PSC financing policy that's available, and we can share it. We are working with stakeholders to improve the management and administration of PSC or Basic Healthcare Provision Fund. We are trying to make sure that we mobilize the private sector to support primary healthcare. In March this year, we held a conference where we invited a lot of stakeholders, and we're happy to know that people like the Dangote Foundation and some other people, they have pledged to support us in making sure that the PSC centers in certain geographies are working. We are still looking forward to more people coming on board in that initiative. We are also collaborating with a lot of other agencies to make sure that we improve the PSC system. Next slide. Next slide, please. Next slide. So we have a lot of strategic interventions to improve primary healthcare delivery. I had like making sure we provide the world minimum healthcare package of the world minimum healthcare package, which includes non-communicable diseases treatment, communicable disease treatment, health education, etc. Making sure that if there is effective monitoring of integrated supporting supervision across all boards, ensuring effective referral system, propagating the world system approach, and making PSC services equitable and affordable to people, and going to all the geographies. In terms of health management information system, we're also making sure that we have a very strong database. In the agency, we have what we call the EMIT system, the electronic management of immunization data, and we are trying to extend it to even beyond immunization to the other areas. In terms of community participation and empowerment, we're also trying to make sure that we reactivate the already existing ward development committees and village development committees, or where they don't exist, that we establish them. We are trying to improve their capacity by training and also monitoring them through supportive supervision. Next slide. Next slide, please. So why do we really need to invest in primary health care? The simple response is that most of the diseases that are killing people, most of the conditions that are killing children and women and other people can actually be managed at the PAC level. For women, the postpartum hemorrhage, the bleeding, the hypertension in pregnancy, eclampsia, and so many infections, they are the most things that are killing them. And we believe that this can be managed at the PAC centers. For children, malaria, diarrhea, pneumonia, and infections are also the major causes of death. And we believe that if we're able to tackle this at the PAC centers, then we'll be able to reduce morbidity and mortality in Nigeria. Next slide, please. Next slide. So let's just look at the World Health System. I'm sure we have all heard about the World Health System. The world is actually the smallest political unit in the country. And we make sure that at least that there is one operational PAC facility in each ward. And each ward covers about 10,000 to 30,000 people. Like I said, we are operating the World Minimum Healthcare Package, providing a package of interventions, including treatment for communicable diseases, providing child survival services, maternal and child health, nutrition, etc. Next slide, please. So this is the system. We have the PAC services. Here we are showing they are clustered around the general hospital. There are midwives, there are CHUs, there are village health workers that are working in the PAC facilities. And we expect that each ward will have these facilities. Then they refer to the general hospital where necessary. And from the general hospital, there will be a referral to the tertiary hospitals where necessary. Next slide, please. And our goal is to ensure that everybody is covered. So our goal in the ward system is also to make sure that there is an effective two-way referral system. We refer from the PACs to the general hospitals, to the tertiary hospitals, and then there is also a feedback mechanism to make sure that after they are handled at the higher centers, they are also referred back to the PAC facilities. Next slide. Next slide, please. So, like I have said, we are operating a one functional PAC center in every ward, or also called revitalization of PAC. But this does not involve building new facilities, because I'm sure people will say, MPACDA, you want to continue building. No, it does not involve building new facilities. Sometimes it involves renovation. It involves that it means that we are able to deliver integrated health services, go to outreaches, have human resources at these centers, make sure that we have equipment, infrastructure at those levels, that there's data management, and there's adequate supervision and strong collaboration with other sectors. Next slide, please. Next slide. So there's a minimum standard. Right now in the PAC system, we have three major types of facilities, the type 1, type 2, and type 3 across the local governments. But as of now, we believe that if we are able to have the type 2, we'll be able to provide adequate primary health care services to our people. Next slide, please. Next slide. So this is a view of what we consider our type 2. It has a health facility that has residential quarters for the nurses and midwives. It is fenced for security. There is provision of water. Next slide. So that you see all that the type 2, like I have said, it has a house for the midwives. They live there, they're able to provide a 24-hour service. they're able to address people that come at whatever time of the day, and there is adequate stock of essential drugs and other consumables. Next slide, please. So apart from the supply, on the supply side, we also make sure that we need adequate human resources. So we need to look at the recruitment, deployment, and training. Infrastructure, I've already mentioned, there needs to be commodities at the health centers, equipment, and I've mentioned the need for monitoring and supervision and surveys. And also we need to make sure that we don't just have the facilities, that there is enough demand. And that is why we are strengthening also the community structures, the World Development Committees. Next slide, please. Next slide. So yes, we have these facilities, but we need to make sure that we are able to mobilize more funding, and we are looking at public sector funding. We are also looking at private sector funding, innovating funding techniques, and also making sure that we maintain our relationship with our partners and receive development assistance for health. Next slide. There are many challenges in the PAC system now, and we all know this. So we have poor access and suboptimal quality. I had dealt with that. The financing is not adequate. We have human resource gaps. We don't have enough health workers at our facilities. And this is part of why people bypass the PACs and go to the other secondary and tertiary facilities. There is limited partnerships with the private sector, and this is what we are currently exploring. Limited community engagement, intersectoral collaboration, which is a major part of PAC, is not, is limited. The use of data is also there. There's poor utilization for evidence, and then there's a gap in leadership, which is why we are working on the PAC under one roof. Next slide, please. Next slide. The way forward, we all need to work together to improve access to comprehensive, equitable services. There is need for us to implement reforms to improve funding of the PAC system. We had actually been advocating for an increase of the basic healthcare from 1% to 2%, and we are hoping that we'll be able to get an assent. There is need to improve human resources planning and distribution, improve partnership, both within the private sector, the academia, the traditional and religious leaders, which we have achieved a lot through that in the immunization sector, but we want to expand that to cover the entire PAC. And there's also need to scale up innovative methods and technologies. I had mentioned the EMIT system that we are using to make sure that we are able to use technology to improve the entire PAC system. Next slide, please. Next slide. Next slide, please.
Yeah, it's coming. I think it's network.
So in conclusion, before the slide comes, we will all agree that primary healthcare remains the cornerstone of the healthcare system in Nigeria and is a key requirement for achieving the national health security agenda, which is very critical for achievement of universal health coverage and also the sustainable development goals. If we can transform and fully make primary healthcare functional, we can indeed address the healthcare needs of more than 70% of the Nigerian people. So if we can transform and fully make PAC operational, we can address more than 70% of the healthcare of the Nigerian people, and they don't need to go to the general hospitals and the tertiary hospitals, and those levels of care will be left to face their main responsibilities of research, etc. And despite the achievement we have so far made in primary healthcare sector in terms of controlling and eradicating Ebola and polio, and also controlling the COVID-19 pandemic, a lot still needs to be done. So we all need to support the improvement in the PAC sector, making sure that we work together to improve it. Nigerian poor health indices are indeed a reflection of the fragility that we have currently in the PAC system. So we believe that we all need to work together to make sure that we join hands to revitalize, transform, and strengthen the Nigerian PSC system to improve the health status of the Nigerian people and the human capital health. Thank you very much. Next slide is just to say thank you very much. We are sorry for the technical hitch. We don't know why the slide.
Okay.
Yeah, thank you.
Ladies and gentlemen, thank you very much. Dr. Ngozi Nwosu, thank you for this presentation. I think you've more or less set the stage for what is to come next. You have covered almost all the areas of interest to us at PEEF, and I think our audience at large regarding primary health care. In fact, your paper has more or less set the stage for the next speaker, who incidentally is myself, because my emphasis was also going to be on primary health care being the place to start if we are ready to give Nigerians the quality, the quantity, and the type of health they deserve. So thank you very much. I think you really covered quite a lot. I was quite interested also in your plans for the human resource for health. That remains the main problem for primary health care. And indeed, we agree with you, most residents and communities will bypass primary health care centers and go all the way to tertiary hospitals, which is not the right thing to do. And I'm glad you're beginning to refer. What they want to know is if, when necessary, primary health care physicians will do the right thing by referring them in good time to the right place, the right people to get the care they need and save lives. So I'm glad you're doing that already. Funding, we shall be looking at funding, and indeed 1% to 2% will not serve the purpose of almost 770 centers across Nigeria. I suppose you mentioned you will not be building new centers, and I don't think you need to build new, because late Professor Kuti built, I think, 774 health centers across Nigeria, and going by what you said, 1 PHC per ward. And I suppose those still exist. I have pictures, which I'll show later, of what the primary healthcare centers in some areas look like today. And I think we shall all be very disappointed. But they can be revamped. Like you said, we don't need to build new ones. We need to renovate. So thank you very much. I will be stopping on, I will be commenting again on some of the things you mentioned, because primary healthcare, like I said, is a pivot to what we want to do, but to do what we plan to do, to give every Nigerian care at their homes. They don't have to travel, at least for primary services. So thank you once again. I yield the microphone back to the chairman at this point. Thank you very much.
Thank you.
Okay. So Dr. Kujo, we need to have maybe comments from the delegates.
Okay.
Questions or comments from delegates. If anybody could raise their hand or.
Yeah, if that is so, I thought initially we said we shall go through all the presentations one after the other. But yes, I think it's appropriate to have the comments at this point. So let's look at the comments. Yes, somebody is, okay, that's a thank you to Dr. Ngozi. The next one, let me see for any particular questions.
Q&A, there are two.
Yes. Wonderful presentation, detailed presentation. Thanks, Dr. Ngozi, lovely work that NPHCD is doing. I think that's about all we have for now, sir.
Okay, Dr. Kujo, on the Q&A,
okay, Q&A. Okay, let's see. Yes, there are indeed. Okay, yes, sir. The first question is by Ife Yusuf. Why is HRH planning and distribution? Why is HRH planning and distribution and medicine availability not included in the strategic intervention? Okay. And the second question is also by Ife Yusuf. What approach is currently in place to ensure effective referral and follow-up system across the different levels? Dr. Ngozi, will you want to address those two questions? Is
Yes.
Dr. Ngozi still with us?
Yes, I'm here and I will address them. Thank you
Okay,
very
thank
much. So if you look through the body of the presentation, actually I have talked about human resources for health planning and distribution as a major thing that the agency is looking at. Without the human resources, we are wasting our time in the PSCs. And that is why as far back as 2013 to 2018, I was actually the director in charge of human resources for health in the NPHCDA. That time we started what we call the midwifery services scheme. And by 2019, we also had another initiative, the expanded midwifery services scheme, where we deployed human resources across the facilities, especially in the underserved areas. So we had, the problem was the issue around funding and that, but we are using about 5% to 10% of the money from the Basic Healthcare Provision Fund to make sure that we address this. We're also working with the Nursing and Midwifery Council and all the other regulatory bodies to make sure that planning for human resources is an essential part of what we do for PSC. So sorry is not omitted. We actually know that that is the problem, and that is one area my ED has been shouting about. We are presently working on the what we call expanded midwifery services system. To make sure that there are also PSCs in a bid to make sure that when people come to the facilities, they're able to see doctors and nurses working there, even before the country is able to access the funding to recruit the people that will stay for keeps. The second question is the approach we are using for medicine. No. We have a lot of things around medicines and consumables. Again, if you go to a facility and there are no medicines, then like maybe I should quote Babangida during his regime, he will say that the hospitals have become mere consulting clinics. That is one area we are not. We make sure that there's a lot of supply of drugs and consumables to all our facilities. And then what are we doing to make the referral system? We're also making sure that we train the human resources in our facilities. We are able to tell them of the interventions that they should handle at the PSC facilities, and then the one that they must refer and prompt referral. We're also making sure that we provide the referral forms. We make sure that they're available in the facilities, and then the visiting doctors that we are working with, that they are able also to come and support us in those areas. So yes, we are making sure that they are not dealing with cases they should not deal with. Thank you very much.
Okay, I don't think we have any more.
I think there's another question.
There's a new question. Yes, there's a new question.
Yes, there's a new question asking about the statistics of PSC. We have
what approach is currently in place to ensure effective referral? Okay, that has been dealt with.
I have addressed that. I think
there is a need to integrate medicine supply by working with state DMAs, drug management agencies, and thereby prevent parallel supply chains. What is the NHCDA doing about that?
We will look at that collaboration, but we're already also collaborating with the state primary health care boards. Like I said, there's the centralization of management. At the NPHCDA, we are here at the national level. We have established the state primary health care agencies across the 36 states and the FCTs. And these are the people that are collaborating with the state agencies that you mentioned to make sure that, you know, that we don't have a parallel system. And that's it. We just had a meeting with them on Tuesday and Wednesday and Thursday last week, guiding them on the way to go. And we're making sure that that they are doing what they are told. They're improving. Some of the state agencies are new. Some of them, we hold regular onboarding courses for them, trying to make them aware of their responsibilities and the way to improve practice at their various state levels, and even beyond, getting down to the ward and the LGS.
I don't know whether there's another question.
Chairman, somebody has raised his hand. Ismail Abiodun Shokoni, can we allow him to talk?
Please.
Are you asking me, sir?
Yes, should we?
Yes, sir. He might talk. He might so do, sir.
Okay. So, Mr. Shokoni, you have the mic. Can you please make your contribution? Mr. Shokoni? He has been able to speak, but he's not talking, so.
Can you please type his question?
Yeah.
Remove this, I can't see.
I think we may proceed because time is going.
Can see a question, what is PSCDA doing to ensure accountability of basic healthcare provision fund? The PA. We're doing a lot. The monitoring and supervision mechanism that comes straight from the Office of the Minister of Health. So it's not just PSCDA being conducted, and there are checks and balances and accountability mechanisms, even within the PSC. So the account that they are, the money is sent to the state sends to the PSC facilities, and they are monitored. They are monitored to see how, and the money that is even getting to them is not, there is not so much, as of now is about 300 per quarter. We follow it very closely. And if any facility is not to account for the money they are giving, they are reported for the next period. So the accountability mechanisms are there to make sure that they do not mismanage. Thank you.
Yeah, Dr. Rabi Musa, shall we proceed?
Yes, we can.
Yeah, please.
Dr. Shaibu?
Engineer
Yeah, with you.
has raised his hand. Maybe the last one, Dr. Shaibu. The
Okay,
teacher has raised his hand. Is maybe the last one. He can go ahead and make his contribution. Then we'll move to the next speaker.
Yes, sir.
Please proceed. Don't worry about me. It was a mistake.
All right. Thank you very much, sir. Thank you very much, Dr. Kojo, for moderating that session. And thank you very much, Dr. Ngozi. And on our behalf, please, our appreciation to the CEO, National Primary Health Development Agency. We appreciate it. Thank you very much. Our next paper, incidentally, I hope, Dr. Kojo, you are ready to take your paper immediately. If you're okay with that. Okay.
Yeah, is the IT standing by ready to assist?
Yes, your next paper, the next paper is NHIA as a transition to universal health coverage, the imperatives. This paper will be presented by Dr. Kojo, who we have already introduced. The moderator of this session will be Dr. Ramatu Hassan. Dr. Ramatu Hassan is Chief Consultant at ASFA Medicals. She retired from the Federal Ministry of Health as a director and the Nigerian National Coordinator for Cancer Program. At this point, I want to invite Dr. Hassan, and I'll yield the floor to her to moderate this session. Madam, you're most welcome.
Yes, thank you very much. Good morning, good afternoon, good evening to all the distinguished attendees to this very important interaction. Without wasting much time, I would want to introduce the topic, which fortunately has already been done, but I'll just repeat it again for the sake of those that might have missed. That is the Nigerian Health Insurance Act as a transition to universal health coverage. And we have our very erudite Dr. Charles Kojo, that will look at the imperatives regarding the National Health Insurance Act as a transition to universal health coverage. May I, at this point, invite Dr. Charles Kojo to present his paper. Dr. Charles Kojo, sir.
Thank you, Dr. Ramatu Hassan. And I wish to stand on all existing protocols and to say good morning, good afternoon, good evening to our viewers across the world. That's my little bio, and I think I've been introduced adequately. Next slide, please. Next slide, please. Do I have assistance? Thank you. The next one, please. That's just my introduction still there. Next one, please. Next one, universal health access, yes. So primarily my job this afternoon, really, or this morning, is to look at the imperatives for transiting the National Health Insurance Authority. I want to correct that, not the act itself, but the authority itself, to covering the whole nation. Previous speakers have highlighted one of the major problems, and one of the real essential problem, what is the main imperative, is providing funding. We need money to do this. And how do we raise the money is going to be my focus in my presentation, because we've identified that as a first imperative. So next slide, please. So looking at Universal Health Access Card, which I'll mention, the Health Bank, the National Health Bank, primary healthcare has just been adequately dealt with by the previous speaker. I think that was very good. Secondary healthcare was mentioned, and tertiary was mentioned as well as the next levels of care stemming from primary healthcare. Next slide, please. Next slide, please. IT support. Next slide, please.
Yeah, yes.
So while IT is getting set, okay, thank you. Now you've gone very far. Next one. Okay, so that's fine. That's good. Could you remove? Could I have a complete picture, please? No, go back to slide. Yes, right there. Okay, touch nothing. So we want to look quickly at access, quality and quantity and cost. This is what I usually refer to as the sacred triangle of healthcare. Now, access is imperative if we should cover 200 million Nigerians. They must have a way to access health without the worry of paying out of pocket and without the worry of going broke because they were sick. So I want to emphasize at this point that we can adequately and quickly register all Nigerians into the National Health Insurance Authority scheme. It is doable, and that is using our cell phones. We're all familiar with registering for all sorts of services, including purchases on the web and registering for journals and papers. And so we can register every Nigerian using the cell phone. And as you will see later in my presentation, we now know for a fact that there are so many, Nigerians are online. And it's amazing that there are almost 195 million cell phones in operation, and those should help us. Now, the quality of care, of course, when we provide the institutions starting, like we said earlier, with primary health care, we should be able to ensure that the quality of services received are what they should be. And now cost containment will be the next part I will address. How will we fund the health service such that Nigerians do not have to go broke just because they were sick? Next slide, please. So the National Health Access Card will be used to register all Nigerians online, and they will receive their cards at the offices of the National Health Insurance Authority, which luckily are available nationwide. So every Nigerian should be able to receive their card nationwide, which acts both as an instrument for payment at the point of service for health, as well as a medical records card. Now, next slide, please. Of course, don't worry about the placement on the left. It's just to say the security for these cards are paramount, because to begin with, people's medical record will be on it. And in addition, it's a payment instrument. It's an ATM as well. And we shall explain shortly how this will work. Next slide, please. So the Nigerian Communications Center have told us about, I told you earlier that almost 95 million cell phones are in use in Nigeria. These subscriptions you see on the screen have been overtaken by events. We're now unifying all subscribers into one scheme. So moving forward and transiting from where we are now to a coverage for all Nigerians, the proposal is to say every Nigerian who owns a cell phone pays 20 naira per day for health coverage. This transmits, if you do the numbers, to 1.9 trillion naira per annum, just for provision of healthcare to all Nigerians. Next slide, please. Okay, so how do you use the card? Well, this basically just shows a schematic diagram of arrival at point of service, getting the treatment you need, and on your way out, you stop and provide your card for payment. You see written at the bottom, the health bank, and I will address that in the next slide. Next slide, please. Okay, so now this is the tele density in Nigeria at the moment. And as you can see on the left-hand side of the slide, there are 206 million phones in use. And on the right-hand side, you can see the teledensity. And at the bottom, month by month, you can see the number of subscribers. And December of 21, for which we have a figure at the end of this slide, is showing 195, and it has increased all the way to 209 million by August of this year, 209 million subscribers. And so, in fact, the income that was previously planned or predicted is more than 1.9 trillion if we go with this at 20 naira per day per subscriber. Next slide, please. And you can see the contribution of telecoms industry to our GDP. It is varying between 12.6% and all the way to 14%, and sometimes, yes, that is the minimum being about 9.2%. Next slide, please. Okay, so this is the main contribution of this presentation. How do we transit the National Health Insurance Agency from being an insurance agency primarily to becoming also the payer for all Nigerians? In other words, we're saying we want to see the NHIA transmuted or made into a national health bank. And the reasons for this are simple. The NHIA currently has offices across Nigeria, has staff across Nigeria, is familiar with health insurance. Therefore, if we're able to put together the fund to meet the cost of the healthcare for all Nigerians through subscription, through our phones, and be able to generate what we now see to be almost 2 trillion. We understand, of course, that the income from GSM in Nigeria is 22 trillion naira per annum. That was what it was last year. And so all we're trying to get out of that is 2 trillion to provide for Nigerian health. In addition to that sum, we also know there's a budget for health, there are other donors for health, there are partners for health, as we heard from the previous speaker. If we were to bring all those funds into the National Health Bank, we're presumably looking at 3 to 3.5 trillion naira for health. Next slide, please. So what does the health bank do? Number one, we have noticed from the last speaker that primary health care needs money. And that is where to look. That is where the main population of Nigerians resides in the communities around the cities. Therefore, the primary health care needs to be where we start from. And they are able, as we saw, provide, if we were to implement the type of centers that was mentioned, which has adequate facilities to meet most needs of communities, we should be able to fund it adequately. We should be able to give those centers the human resource for health, which they need. In addition, we should be able to provide the infrastructure for them. And it was mentioned, water supply, power supply. These we have calculated not to be as much as people think. The power supply, water supply from a borehole and a generator should not be more than 15 to 20 million naira per center. In addition to revamping the center, building the accommodation for the nurses, we propose also for the doctors, if it were possible to have the doctors resident on campus, the nurses on campus, the lab scientists on campus, we should be able to really give those communities the care they need when they need it, and that should satisfy that level of care. It's also important that they're able to refer patients to the secondary healthcare centers when they're unable to handle them. The primary thing that would be needed at that point is transportation. We are strongly recommending that the prototype that has been done of a tricycle, otherwise known as keke napep, that has been transformed into a small mobile ambulance should be available at every healthcare center, every PHC. It's disgraceful to recall the incidents of a case where a pregnant woman had to be transferred from a PHC to a secondary center on a wheelbarrow. That was totally unacceptable for a country like Nigeria. So we strongly recommend a simple mode of transportation. A tricycle ambulance should be able to move patients from their primary care centers to the next level of care. Then tertiary healthcare, the National Health Bank will be able to support those centers as well with funding. We are still crunching the numbers, but if we're able to raise up to 3 trillion, like we have said, then that should be adequate to do that. In the area of medical equipment, funding again is needed. We are very poorly equipped in Nigeria. The truth be told, our health centers still need a lot to be desired. So funding can be accessed from the health bank at single-digit interest rates and a tenure that is reasonable for the sector, especially looking at private centers who need to source for funds from banks. Commercial banks do not usually understand health. Health is a different kettle of fish for most. Health demands a longer tenure for payment and a single-digit interest rate because it's not profit-oriented. It is more of a social service. And then we want to move to pharmaceuticals. We should begin to manufacture most of our drugs. Again, the health bank can intervene and help in trying to start and build new pharmaceutical firms that can manufacture basic drugs. We're not looking at very basic drugs that are used in the primary healthcare centers and even secondary centers, and other drugs eventually. And that brings me to the final part on this graph. Trainings abroad. In the past, our doctors in training in tertiary centers at their 4th year of their residency spent 1 year abroad. That was a very useful, very helpful set of affairs for doctors because they were exposed to world-class standards, and most of them returned to Nigeria to practice. and that enhanced the quality of care in Nigeria. We want to see that reintroduced through the health bank. Next slide, please. So I've more or less mentioned what the health bank should be doing through the health bank intervention and infrastructural development, providing the funds at single-digit interest rate, preferably pegged above 5%, and the tenure not less than 10 years, enabling practitioners in the field, doctors, pharmacists, lab scientists, etc., who want to set up centers to support the health sector, to do so willingly without the fear of becoming bankrupt. Next slide, please. So how will the health bank be managed? Well, we want to hand this over to NHIA. Please change NHIS to its new name, NHIA. They will administer the National Health Bank. In other words, the need might be there to return to Parliament, to return to the National Assembly to get the law changed, making NHIA, which is why this is the next step. This is the transition we are looking for. It's a good thing, and we want to commend the government and everybody involved in passing the act and creating the NHIA. Well, the transition we're talking here about this morning is transiting from National Health Insurance Agency to the National Health Bank. Next slide, please. And this is what we look for when we create this bank: universal health coverage. It will have access, public health will be primary through the PHCs, etc. And so this is what it should be looking at, which implies that the staff at the NHIA as it stands today, there will be need for an audit, see who could be trained in the banking arm of its activities and who remains in the insurance arm. And then we take it from there. Next slide, please. So this is the current state of some primary health centers. I mentioned to Dr. Ngozi this morning after her lecture that we have photographs, and these are part of the photographs. This is an appalling state of some of the health centers that were built some years ago across Nigeria. About 778 of them were built in almost every ward or every community in Nigeria. They need to be resuscitated, they need to be revamped, they need to be rebuilt. I can see NYSC people, students, coppers some years ago tried to redecorate this particular one whose roof has now been blown off. These can be renovated, and here again, the National Health Bank will come in to provide the funding. I am proposing that the contractors who will do this should be primarily drawn from the communities in which those centers are situated, to recognize that this is for their community and that to remain within reasonable budget. Next slide, please. In addition, of course, this will create jobs, and we see the jobs in painting, carpentry, masonry, and so on that were created across our communities for people who will build the centers. And this is where the primary healthcare center should focus. I must say again, I was very impressed with Dr. Ngozi this month. Dr. Nwosu, you did a very good job. Thank you very much. You've really done my job for me of what you should be doing, and we hope with the financial support that you will need coming through the National Health Bank, you'll be able to do most of those things. Next slide, please. At the bottom, you can see the ATM card. I should briefly say what that should do. So the intention is that every Nigerian, when registered with the system, will receive a card, which is both an ATM card for payment at the health centers they attend, and also their medical records. Now, at every center, they will have a system in place, an IT system in place. So insert that card, and the doctor seeing the patient will only ask for the PIN from the patient to download the patient's previous and all records, all medical records, including x-rays, lab tests, previous medications, previous diagnosis, and so on. This, we believe, will enhance the quality of care automatically, because now the doctors have facts to work with every patient that presents before them. In addition, it's a payment instrument. When a patient attends, they need not worry ever again about paying out of pocket. All they need to do is present this card, and the POS machine is present at every center that takes care of them, every pharmacy, every lab scientist, and they can pay immediately to the provider. This has been a big problem. Providers are being owed years and years of unpaid fees. And this is destroying the current state of affairs in the health sector. If the providers can be assured of POS, point of service payment, it will enhance their ability to provide care, and the ability to even buy new equipment, keep their inventory up to date, pay their salaries, and maintain their buildings. I think we strongly recommend that this should be part of the new transition. Next slide, please. So this is the bank. The figure you see there has been changed because of inflation to 20 naira per day per person. And now with that and with your card, you do not have to pay out of pocket when you receive care. Next slide, please. So secondary care, of course, the general hospitals will be available to support the PHCs. So the referral centers from PHCs to secondary care must be returned to how it used to be and maintained. And they, at the secondary care centers, should be ready to make referrals to the tertiary care centers. But no patient on any account should be allowed to access care at tertiary or secondary without first going to their primary healthcare centers. That should reduce cost and also will create a better flow of care. In addition, as was mentioned this morning by the previous speaker, there should be a way of return information, the loop. There should be feedback to the referring centers so that knowledge can also be shared as to what happened and what you did that they couldn't do. Next slide, please. The NCC has been extremely helpful. We got some data from them, but the next thing they will do, of course, is the registration. They'll support us with that. They'll also support us with the deduction of the 20 naira per day that should be transmitted directly from the cell phones of the subscribers to the National Bank every day. Next slide, please. So the tertiary care will receive help from the National Health Bank as needed, in addition to other sources of funding that they already have. And they'll continue to give services at the tertiary care level of dialysis, transplants, and other heart surgeries and so on, which are beginning to happen in Nigeria. And we're happy to report that. We're moving towards providing adequate care at that level to Nigerians. What is still needed is funding. And again, here is where we strongly suggest that the National Health Bank should step in. Next slide, please. Still on tertiary healthcare, next slide, please. The fees have changed. It's now a standard 20 naira per day per Nigerian. Previously, the idea was to have a silver card, a gold card, a diamond card, and we think that was not equity. That was not equitable at all. All Nigerians should have access to the same quality of care, irrespective of ability to pay. Next slide, please. Yes, next slide, please. The custodian of our funds will be the Health Bank. Now, checks and balances. We all know, and this is a fact, when there's money, people want to make a lot of it. We want to be sure that indeed the Health Bank is not paying for services that were not given. And so we want to have in place IT support, artificial intelligence support, and the ability of the system to track any undue services or undue payments, etc., from the HCPs to the MDC and Justice. So what will be happening is from time to time, there will be visits to those centers by officials from the bank to ensure that there's compliance. especially in payment. Artificial intelligence will help us to see centers that are beginning to do things outside their scope or beginning to charge fees not agreed previously with the scheme, etc. And if doctors or providers are found to be wanting, they may be reported to the MDCN. And if necessary, if there has been a case of or suspicion of fraud, then the justice system will be asked to step in. And if any of such centers or doctors are found guilty, they'll be struck off the register of doctors and never be allowed to practice again in Nigeria. And they may also face the other aspect, which is criminal, and might have to be sent to jail. So we want to be sure that the system has its checks and balances to prevent any fraudulent activity. Next slide, please. So let's work together towards good health and well-being for all. Next one, we want to leave no one behind. I was happy Dr. Ngozi also said that we leave no one behind. Thank you for listening.
Thank you very much, sir.
Sorry? Hello? Dr. Shaibu? Dr.
Hello?
Musa? Yes.
No. The moderator will take over now, Dr. Ramon Hassan.
Yes, the moderator will stay in charge.
Am I audible? Hello?
Yes, you're audible.
Okay, fine. Thank you so much for that very interesting and very educative treatise. If I may go through it for the benefit of our audience to just pick up the salient points, we were able to understand from the presentation about the issue of the quality of services and the kind of transit.
Yes. Doctor, we have some questions on the screen. Have you noticed them? Can you hear me?
I can hear you. I can hear you.
Yes, there's a question on the screen from Ismaila Abiodun Sekoni.
But I should go through some of your points and we go to the questions. And
okay.
If that's what you want.
Okay, fine. That's good. Yes.
Okay. Since you want to look at the questions, we have one by
I can't hear you. Dr. Amatu, you are frozen. Dr. Hassan?
You that
take this off. No, I'm waiting for her. Sorry. Yes. Okay, I think our moderator is frozen. May I read the question?
Yes, please
Dr.
go ahead.
Shaibu?
Yes,
okay.
Okay, let me fill it for her meanwhile. There are two questions.
Please.
There are two questions here. The first one is saying, what is the relationship of the health services personnel leaving the country have on primary health care per ward policy? I think this looks like a previous. That's the first question.
No, but that's okay. That's okay.
Yes.
I will take it now. So quickly,
Right.
I'll answer that quickly. Well, as we have seen, why are people leaving the country? We know the reasons. So how do we stop that, really? I think what the previous speaker also mentioned, making the primary healthcare centers conducive to work, making the salary structure different from the rest of those in urban cities to encourage people together. But most importantly, I think we can provide the human resource for health from the medical and nursing side through the National Youth Service Corps. It should become compulsory that no doctor should serve for the NYSC in any urban center. They should all be encouraged to move to the communities where we have PACs and to serve their 1 year there. And so we shall have continuous flow of doctors and nurses with BScs to those centers. I think that might help for the interim until we restructure the health service human resource remuneration to keep doctors at home.
Thank you very much, Dr. Kojo. There's yet a second question.
Okay.
And I'll just read it verbatim.
Okay.
The challenge with
Dr. Shao,
Okay.
the moderator is back.
moderator is back. Yeah, thank you.
Yeah,
Madam.
thank you for, yes, thank you for your assistance. The network got me off the session. There's a second question by Ifi Yusuf. And I think the speaker was about to respond to that while I was trying to get back. That is,
Okay.
Yes.
Okay, Dr. Yusuf, thank you for this question. Indeed, it is very important, and this is where the National Health Card, Access Card, will come in, because it's also a payment instrument, which means henceforth, doctors already have agreement with the National Health Bank on tariff. So if you have to do any sort, you do not have to wait for approval. You have to just proceed and do the needful. And when you're done, the patient pays at the point of service, pays to your facility directly using their access card, which is also a payment instrument. It's an ATM, and the bill will be charged directly to the National Health Bank, and you will be paid. There will only be difficulties if it is discovered that the services claimed to have been given have not actually been given, which is where the checks and balances will kick in. Thank you.
The rest of what I'm seeing are just comments. I cannot see another question again.
Okay.
So,
Yeah, the moderator, somebody has raised his hand. Dikim Egbo has raised his hand.
okay.
Dikim Egbo, yeah.
Yeah, thank you very much. I call you Prof for that presentation. You know, I like innovation, but I also want to think about where we're putting the innovation. You know, because I believe there's a lot of factors that will make the bank work. My experience in Lagos State, where we work with Bank of Industry, show that some medical directors are not really interested in systems. They don't have financial management system, a number of them, because we brought the banks, we brought private medical practitioner guild of medical directors together with the state government. We brokered the relationship to see how can we support them to buy materials, how can we support them to buy the equipment they desire, how can we support them? Some of them were operating out of a car garage and all that. You know, we're looking for ways, you know, so I would think also we should look at how we build, because my place, they say you're preparing a concoction for a madman, but you don't know if the madman will drink the concoction. So I think there are some grassroots work that we need to do to change our attitude. I don't want to start presenting my presentation before that, but we need to work on attitude. We need to work on our character, on our behavior, because we do not lack anything. Every time I go out and I see what is going on in other countries, I know we've done that. We have them documented. We have the best documented policies in the world, not in Africa, but they are not implemented. So I will say, let's look inward, look at Bank of Industry. How do we get it? They have lots of money to support what we're talking about, you know. So that's one. The other thing I just wanted to talk about is when we look at the way things are done, because most of the time we put things in government's hands. How do we put this Bank of Industry out of government control? Because if we leave it in government control, we will land in the same destination. So I think that's, I don't want to continue because I still have my own session coming. Thank you.
Thank you very much, sir. Yes, it is proposed that the National Health Bank will be independent to the extent that it can be independent, not necessarily under the government. I think when we go back to Parliament to have the modification of the Act of the NHIA, transmitting it into a bank, that could be, be inserted to ensure its autonomy and be able to work independently. Thank you. Any other question, Dr. Hassan? Dr. Ramatu Hassan?
Gaffar's hand is up. Gaffar's hand is up.
Okay. Who gives him access?
Okay, thank you very much, and good afternoon, everyone. Thank you, Dr. Gamaik. So good presentations, Dr. Pujo. So my contribution is this, as it's in line with what Dr. Gamaik just started. I think we have to segment the health market and to see where the health bank or private sector can, had great values. So if you look at health markets, we have services that are available where majority of Nigerians are not able to afford. Then we have situation where some services are not readily available, but we have Nigerians that are able to pay for those services. I think when we are talking about health bank, the health bank should be focusing on those services that are not readily available. And we have people that are able to pay for those services. And because their services are not available and they are going abroad to pay for that, can we channel private resources? Because if you channel private resources bank or something, it's the money that you have to recoup. It's not free. It's not grant. It could be loan or other things. So we have to look at services that are available, and the services that are not available. And we have Nigerians that are going to China, going to India, going to the UK, and all those stuff like that to access those services. But at the same time, when it comes to services that are available and we don't have, people are not able to afford it. That's why we should look at the vulnerable group fund, basic care provision fund, and everything to be able to mobilize pool fund to take care of that. That's my contribution for now. Over. Thank you.
Good. Thank you very much, sir. Thank you very much, Dr. Gaffar. Moderator, over to you, ma'am.
Dr. Ike has raised his hand. Dr. Hassan.
Dr. Ike, please proceed.
I went to the nearest hospital that I've chosen, and I said, and if my issue is beyond the primary, you will be referred to secondary or tertiary, as it may be. The next one is the right to choose a provider.
Hello.
Yeah, hello.
Can you hear me?
Yes, who is speaking, please?
Yeah, Dr. Eke.
Dr. Eke, please
Hello,
progress. Proceed, please.
I want to what Deacon Mike Abel said. It's quite very important. I think that the main topic we are talking is on primary care. All right, we are talking about primary health care and universal health care. I think it is better. Let us deal extensively on that. Dr. Abel had mentioned something we have tried to do in the past with this Bank of Industries. A time was when the National Health Insurance Scheme, the National Primary Healthcare Development Agency, the World Bank, and Bank of Industry entered into an extensive engagement. What were we trying to achieve?
we looked at the issues that will correct. Like if somebody asks about brain drain, how do we talk about that? We know that we could get people from the communities who have medical knowledge, nurses, midwives, because primary care is not necessarily supposed to be run by doctors. We will run with the technology that is available to us at every point in time. And we did that work extensively. What we were working was that the Bank of Industries will provide loans to people, and in our rural communities, nurses, midwives retired, doctors retired, they will take over all these primary providers or primary care providers within their environs and get these loans and run them using the private sector model. Because part of the challenge we are still having, which we are seeing every day, is this idea of the government funding both the demand and the supply aspect of healthcare. I think it is becoming very, very important that we begin to look at, like Gafar said, how do we bring the private sector into handling some of these service delivery issues? And that will free a lot of money for government to concentrate on those areas of health where they will touch. So that is what I want to contribute into. Thank you very much.
Thank you, Dr. Eke Jonathan. Quickly, this scheme, the bank will really concentrate also on the private sector, because we know from the Guild of Medical Directors, where I was a former president, that 70 to 75% of the healthcare needs of Nigerians is covered by the private sector. We also know about the Bank of Industries, but they only support a portion of the health need. I think they do infrastructure, but they don't do equipment, or they do equipment, but not infrastructure. So I'm not sure now which aspect. So we still need a payer. We still need a funder for the aspect that the Bank of Industry will not cover. But indeed, yes, we are aware also of the intervention fund sitting at the World Bank. At one time, we were informed it was $1 billion earmarked for Nigeria, but very few people access that fund. And so indeed, the money is there, but it's getting it to the people who need it. And I agree with you absolutely. The private health sector should be supported, because they are those who shoulder 70 to 80% of the needs of Nigerians. Thank you. Thank you, Dr. Eke. Moderator, ma'am.
Right to complain.
Thank you very much.
You complain to the next.
Please, somebody needs to be muted. There's a parallel program running in the background.
Hello, thank you very much, Dr. Sal Kujo, for this very brilliant presentation. I really congratulate Nigerians for having great thinkers like Dr. Kujo, with this solution. For me, I think the little tweak I will propose is to separate the function of the banking business from the health insurance kind of work in this proposal. What do I mean by this? My suggestion will now be that the National Bank can still provide some payment for services for vulnerable, and that can now be done through the NHIA system. So NHIA can be structured, can be tweaked a little to be able to absorb that. That will now enhance the funding for the basic healthcare provision fund and all the equity funds that we have in the various states in the federation. So certain percentage of the amount that goes into that can be channeled to NHIA, that can be used solely to enhance payment of healthcare services for the 85 million vulnerable that we have in the country. So that will increase the pool for the vulnerable programs that we have in the country. But on the other side, certain percentage of that money being generated can now be established into the National Health Bank. And the National Health Bank, a little tweak here is that NHIS is not structured as a banking industry. So they might not have the right capacity to manage dishing out loan to healthcare providers. So I believe a proper banking system with the right people that can be given the right training to understand the uniqueness of healthcare system, the uniqueness of the nuances around healthcare delivery, can now be recruited to establish a proper bank. People with banking background can now be established can now be used to establish a proper bank that can now manage that component of the system. However, taking from the comment from our elder and Dr. Eki from the experience of the National Industrial Bank, I think one of the things that can be done to address some of those issues is that instead of using any collateral, the license of the qualified healthcare provider can now be used. And MDCN will now also be in the picture, that if the person is not able to repay, then MDCN can now step in and ensure that that person is forced to pay or his license can be put at stake. Secondly, some entrepreneurship training can now be built either in the medical school, or for anybody that has indicated interest, the bank can shoulder responsibility for doing some entrepreneurship training. Because the truth is, doctors, nurses, and other healthcare providers lack this basic training. And that is why you have a lot of problems with the way they even manage the private healthcare facilities that they establish. So some level of training can be done for people that have indicated interest and are qualified to take this loan as a compulsory entry point for you to access this kind of loan. But I still will want to congratulate Nigeria that this is really a very noble idea, and it requires all hands to be on deck in order to pursue it vigorously. Thank you very much.
Thank you, Dayabu Yusuf. Thank you very much indeed. Wonderful contribution. Thank you. I've taken notes of some of the points you raised, and we shall incorporate it in the next draft. Moderator?
Dr. Shabu. I think the moderator is having connectivity challenges. So Dr.
All right.
Shabu?
I think he also. So Dr. Mosarabiu, may you take over, sir, to the next speaker.
Okay. Thank you very much, Dr. Kujo, for that excellent presentation. As always, it's been very good to get this reaction about this innovation. Certainly, PEEF is geared towards innovation to make greater positive impacts in the health management of Nigerians. So thank you so much. We're going to move on to the next speaker now. We're privileged to have Dikim Mike Egbo. He has made some intervention earlier on. He's going to take the next session. And the moderator for this session is Dr. Kofi Abubakar. Dr. Kofi Abubakar is also from the National Health Insurance Authority. Dr. Kofi, trying to, please, can you unmute your mic, Dr. Kofi?
Yeah, I have.
Okay, you have. Okay. All right. Then Dr. Dicky Mike Egbo, trying to. We're going to share his presentation.
Is he online?
Yeah, he is. He has made a contribution earlier on.
Okay, I can see him. He's online.
Yes, so we're going to put him on add. Okay, if you just put on your camera, the microphone, then we can see you as well.
Okay.
So, Deacon Ego, can you please put on your camera? I don't know. I can't see. I can't see you. So if you put on your camera, then.
Hello, can you hear me?
Yeah.
Yeah,
Okay.
okay. It's busy.
Okay, we can see you now.
Okay, I need, is the presentation on? I'm trying to.
Yeah, it's on now. I
It's
hope
on.
everybody can see it.
Yes, it's on. I can see from here.
Okay, the moderator, I think you just introduce him and then we can start.
Yeah, okay. So good morning, good afternoon all. And let me just stand on existing protocols. We'll be talking about the implementation of the National Health Insurance Act in Nigeria. And as we know, it has been said Nigeria is a country where we have a lot of policies, plans, and guidelines, but implementation has always been a challenge. As an insider working in the NHIA, I can tell you that this act is one of the single most important legislation passed by this government that is capable of transforming the socio-economic landscape of Nigeria. So without wasting much ado, much time, I'll call on Deacon Mike Ego to give us a highlight on how we can implement this act. Mike, over to you.
Okay, thank you very much. And I stand on the existing protocol. I hope you can all hear me. Can you hear me? Okay.
Yeah, I can hear you from here. Go ahead.
Okay, yeah, this is a topic that is dear to my heart. I've lived all my life fighting for the National Health Bill to act. And so as to talk about the implementation today excites me, but also depresses me. And I'll let you know why very soon. Next slide, sir. Next slide. Okay, very briefly, I know NPHCDA has spoken, the National Health Insurance Agency has spoken, a number of it. I mean, they've all touched on the National Health Act. So the National Health Act is one single most important health reform activity that has taken place in Nigeria in the past 10 years. You know, first, I'll just briefly describe it because there are so many aspects of it that 20 minutes cannot do. So I will try and do justice. I'll pick some areas to talk to, not all the parts. But just briefly, it was developed in 2004 by what was then known as the health agent. Health agents, you know, to bridge the gaps that existed in our national constitution, because our national constitution did not have anything for health. Then it means that 1%, not less than 1% of our consolidated revenue fund will be used for implementing the act, in addition to grants from international health partners, private sector, and other sources. After 10 years of battle with the National Assembly, it was finally passed in December 2014 by the government, by the president of the country at the time, Jonathan Goodluck. And then the first attempt at implementation took place 2 years later. With the establishment of the first technical working group and inauguration of 5 committees. I'll be talking about that shortly. And then, of course, the Basic Healthcare Provision Fund, which was described by the Honorable Minister, the current Honorable Minister, as an irrevocable testament to Nigeria's commitment. Universal health coverage. That was launched in January 2019, the Basic Healthcare Provision Fund. And the first significant funding was received in 2019, 5 years later. I'm not going to go into the struggle because I'm looking at the implementation. Next slide. I was trying to move the slide. I'm sorry. What was the purpose for the Act? Basically, to provide a framework for the regulation. You'll find out whether we have been regulating since the bill was passed into an act, for the development and the management of a national health system, and to set standards for rendering health services in Nigeria. That's the purpose of the Act. Very simple. Next slide. Well, there are different components. There are 7 components of the Act. And the first component is the responsibility for health and eligibility for health services and establishment of national health systems. So it talks about roles and responsibilities. You know, it speaks about the eligibility for health services and establishment of the system, and looking at the function of the Federal Ministry of Health, the eligibility for exemption from payment, and so on. You know, that's the purpose of that thing, that part. The second part is health establishments and technologies. You know, and that basically is looking at the classification of health establishment and technologies, certificate of standards. We will talk about that very soon, about certificate of standards. And the third part was rights and obligation of users and healthcare personnel. How many of us know our rights? Hello? Okay, so it's about rights and obligations of users and healthcare personnel. You know, because not many people know, not even healthcare providers know the right. How many healthcare providers have a copy of the National Health Act? The fourth one is National Health Research and Information System. Before the act was passed, there was a committee that was set up, you know, but we'll talk about it. Then the fifth one is Human Resource for Health. You all know that the right quantity, the training, and to make sure that they are deployed to the right places. Then the control of use of blood products, tissues, and gametes in humans. And the seventh one is regulations and miscellaneous provisions. Next slide. No, you're going back. You're going back. Okay, yes. Now the technical working group and committee. Okay, the technical working groups. I just want to take time to quickly talk about the technical working groups, because when we talk about implementation, are you still hearing me? It looks like a number of us are talking.
You can hear you, sir. Go ahead.
Okay. All right, the technical working group, I mentioned it just now, you know, because this is the team that work on implementation. And the first meeting was held in April of 2016, if I remember, at the Barcelona Hotel. And in that place, the permanent secretary who was representing the minister inaugurated the technical working group. And 5 committees were set up. One was stewardship and governance. I was a member of that committee. Then healthcare financing, equity and investment was another team. The third one was healthcare quality and performance. And the fourth was research, knowledge management, research and knowledge management. And then the last one is advocacy, communication, and social mobilization. These were the 5 committees that were set up under the technical working group. As we speak, only the healthcare financing, equity, and investment that have made progress, real progress that you can see by setting up the basic healthcare provision fund, and they've moved far ahead. Stewardship and governance, we're still struggling because we have coordination issues that are not being handled properly, and the healthcare quality, performance, research, knowledge management, advocacy, communication, you know, a lot of these are still dependent on funding. And my brother, Dr. Kujo, said, funding, funding, funding. And that's why we talk about head bank. Next slide, sir. I'm trying to be fast so that we don't. Next slide. Okay. You're back again. I hope this is okay. What I've done here is to bring out some of the key areas that we should have focused on, but we did not really focus on, or that is not working well. Because when you talk about providing minimum package to Nigerians, when you talk about making every Nigerian healthy as a result of the National Health Act, there are certain things that need to be done. I did say that the the Basic Health Provision Fund is working, but there are certain things that will make it more efficient. One is coordination. We are mandated to develop coordination and operationalization framework to make sure that things are working. Have a steering committee at the national level, the technical working group that I talked about. You have 5 committees that are supposed to be working. For your information, the first one took place in April, about 6 years ago, and the second meeting of the technical working group took place in August this year. So when we talk about implementation, you tell me whether that is, shouldn't the technical working group be meeting every quarter or biannually, you know, at least, or once a year? But the gap will tell you something. The technical review team is internal within the Federal Ministry of Health of how they meet to coordinate the works of the technical working group, the steering committee, because I know well-meaning people from all over the country were brought in for that TWG meeting. So I will come back there, but when you look at coordination, which is very key, because if the National Health Act is going to succeed and is going to make impact, it has to be efficiently and effectively coordinated. Coordination could be looked at in different perspectives. You have internal coordination, then you have external coordination. We have donors coming into the country, they have their programs, they work with the National Planning Commission to fit into national programs, but once in a while, they leave the national program and people go about doing what they want to do. So you find that the National Health Act today, there have been a series of NGOs coming up to hold meetings and call for a meeting on the discussion of the National Health Act. That is not a national forum. So coordination has not been effective. And it's one area we need to look into if the Health Act is going to make any impact in this country. Then certificate of standards. I will read here, you know, I came with a copy because if you look at the Health Act, it says no health personnel, establishment, or technologies can function in Nigeria without a certificate of standard. And certificate of standards must be obtained within 2 years. That means by October 2016 or December 2016. The bill was passed in 2014. And by October or by 2016, every health facility should have obtained a certificate of standard. It is clearly stated here, is the minister shall by regulation, I'm reading from part 2, number 12, A. The minister shall by regulation classify all health establishments and technologies into such categories as may be appropriate based on 1, their role and function within the national health system, their size and location of the communities they serve, the nature and level of health services they are able to provide, their geographical location and geographic reach, the need to structure the delivery of health services in accordance with national norms, standards within an integrated and coordinated national framework. He said, in this case of private health establishment, whether establishment is for profit or not, in the case of federally owned tertiary hospitals, determine the establishment of the hospital board, the management system of such tertiary hospital. And then he said, without being in possession of a certificate of standard, that is number 13, a person, entity, government, or organization shall not establish, construct, modify, or acquire. If you don't have it, that's what the law is saying. It's a law. You shall not establish, construct, modify, or acquire a health establishment, health agency, or health technology. You will not increase the number of beds in or acquire prescribed health technology at a health establishment or health agency. Provide prescribed health services, or D, continue to operate a health establishment, health agency, or health technology after the expiration of 24 months from the date this act was passed. That's in the law. As I speak, there is none, and I repeat, no health facility in this country has a certificate of standard. If I am wrong, I want to be corrected. But this is something that should have been done by the end of the 2nd year. So you see the importance of this. So this is very, and the certificate of standard is very clear. It's a operating health establishment without appropriate certificate of standard shall attract a penalty, sanctions, or imprisonment in the case of an individual. So all of us listening here who run hospitals, some of you should have gone to prison. But we thank God we are in Nigeria, you are not yet in prison. Next slide. Establishment of the Basic Healthcare Provision Fund with overall objective of doing ABC. We all know this, you know, so this is the area that is functioning. It's a major area, but the other areas were major, but they were not done, you know. And then the 4th one is the establishment of PSC agencies by all the states. I know they are all at different levels of performance. And some of them have been face politics, you know, they become political entities. Politicians are using them to make name that they are creating XYZ. Some governors have taken ownership and dictating whether they function or not function. So there are challenges there, you know, that we need to look into. Next slide, please. Where are we? I will just quickly run down this because you've heard them. On April 15th, first technical working group was conducted. That was in Barcelona Hotel. The next one was just August this year. And the one August this year was not something that was planned. It was as a result of the federal government trying to set up a health reform agenda. When we have a National Health Act, Dr. Lekki Mohammed, who was the former director of Planning Research and Statistics, actually sent a letter to the vice president because this was coordinated by the office of the vice president. And I know the current director said this meeting would not have been necessary if we had implemented the National Health Act. That statement alone, for me, means that we have not done what we supposed to have done. I have said earlier on that the 5 technical committees have been established, and only the healthcare financing is functioning. Basic Health Provision Fund launched in January 2019 with clear accountability framework. They have system in place. After the 2000, when it was launched, they were able to get 55.1 billion naira from the 2018 statutory allocation. That's the first time, because even after the bill was formed, we formed the Health Reform HSRC. I'm rushing. You know, to hold government accountable, to make sure that funds are released. We made several presentations to the National Assembly, advocacy visits, just to get funds released. This is an act. This is a law. It is a law that Nigerian government should release that money immediately. But like every other thing, it has not been released until this time. Primary care agencies have been established in most states, like I said, but there are different levels of development. Next, these are the status. There are so many other things that have been done, but a lot of them are workshops and all that. What are the major challenges? A number of them have been stated today, and we know them. We know them. Lack of effective coordination, dysfunctional system. I call it dysfunctional because there's no development partner, no civil society organization, no, whether World Bank or anything, cannot start to do their things if we have an effective coordinating mechanism working in Nigeria. But because there is vacuum, people occupy the space. You know, so our lack of coordination is one major challenge. And the fact that technical working group that is supposed to drive implementation have only met twice in 6 years it shows a lot of dysfunctionality. Then some key implementation processes are dependent on outside interventions. The Federal Ministry of Health will depend on the National Assembly to pass certain bill, will depend on Federal Ministry of Finance to understand why certain monies need to be released. So there are a lot of things that the government is depending on that you find it difficult to blame either the director of planning or at times the minister. You know, so the third one is pace of implementation is determined by the availability of development partner funds. If you look at what has happened to date since the passing of the bill, we can't say how much money Nigeria has put in. Most of the workshops that have been conducted have been paid for by partners. And then we have some of us who have found grace to work for these development partners. We are also trying to manipulate things from there. You either working for UNICEF or working for USAID or working for and then we have become mini gods, mini Nigerian gods that dictate within those entities how Nigeria should function. So these are challenges that we must all take into consideration and find a way of addressing. Then there was also the initial unhealthy competition within the ministry and its agencies. I'm not going to name names, but it's common knowledge. Next slide. I'll soon be done. Major challenges continuing, lack of understanding of the National Health Act among health providers. If we go to major private health facilities today and ask for National Health Act, I'm not going to say how many. Not many will be able to show you a copy. If you go to even our general hospitals, national hospitals, not many will be able to show you a copy of the National Health Act. They attended workshop, they were given those copies went into the shelves and disappeared. Nobody, this should be a reference manual, but not many of us, not many people at the Federal Ministry of Health have read this copy. Not many people. I was at National Council on Health meeting in Sokoto where a commissioner asked questions about it. I said, what does this mean? What is this as you are talking about? That's a commissioner. I challenged him that day. I'm not talking about what I don't know. If you were in Sokoto, you will know that I challenged that commissioner. What are they coming to commission? So we have charity, they say, begins at home. If you're a commissioner and you don't understand the National Health Act, why are you there? The second thing is inadequate strategic engagement and inclusion of civil society. Government always sees civil society as anti-government. Private sector, the same thing, and the media. But clever engagement with CSOs, with the private sectors and the media will make us move faster. So we have to look at these are major challenges. Then weak financial commitment from the states, because some states wait and they say, well, donor will fund this. Is DFID not funding that thing, or is USAID not funding that thing? So they're not ready because there's this donor dependency. There's this syndrome in our mindset that somebody will come. I remember one of my colleagues telling one state commissioner, like, if you don't perform, we're going to withdraw our fund. What did the commissioner, a female, say? He said, well, if you withdraw your fund, another donor will come in. That is our attitude. State conflicts due to differences in the interpretation of the health insurance agency's mandate. I think these are the areas we need to clarify. There need to be more cohesion. We know health is on the concurrent list, but there need to state, there are nobody called state citizen and federal citizen. We're Nigerian citizens, whether you're in the local government or wherever. So we must close our gaps. Next. Yes, I have 2 more slides and I'll keep quiet. Now, required action plan. What do we need to do? You can call it recommendation. You can call it way forward. These are my recommendations and they are based on what other people have been saying. Dr. Lekki, like I said, has sent a letter. I wish I can share that letter here. It's a very powerful letter. We need to review and strengthen the composition and quality of the coordinating unit at Federal Ministry of Health. We do need to. We need to look at the strength of that coordinating unit, because when National Health Act was passed into law, people were picked from the Federal Ministry of Health and other places, say join, without experience, without understanding of what the National Health Act is and what it's supposed to do. So the person that should be there and the system we put in place should look into the content of the National Health Act, the result, the outcome, knowing that the Nigerians are dependent on this to happen. So the people you put there should be persons that you know understand it and are able to drive it. The second point is develop a coordination framework, including monitoring and evaluation for implementation of the Act, an M&E framework. The third one, which I want everybody to listen, and I want us to know, unfortunately, the minister is not here. I wish he was here. I would have emphasized this more. Leadership and membership of the coordinating unit should be based on technical competence, sound knowledge of health systems reform, demonstrated strategic management skills, and experience in cross-functional. How do you manage different teams? Cross-functional team development and management. You must come with some content. It should not be, selection should not be based on years of service, because I'm a deputy director and I've not directed anything, and then you make me to go ahead a strategic organization like this or a strategic activity like this. The way it happened with the national NCDC, because when Dr. Chikwe was brought in, he was not in any service. We fought to ensure that it's not by promotion that you put somebody in NCDC. And that's why the difference we saw during the COVID episode. So we need to take the National Health Act very seriously and make sure that the people who are in the coordinating unit are not career civil servants that have, I'm not saying they don't qualify. If they qualify, by all means, yes, we have very good ones, but we must bring a team that is diversified, that is able to make decisions and not be quoting civil service rules. The next point is develop criteria for selecting members into the technical working groups and committees. We make this mistake all the time because, oh, I forgot. My introduction was I work for Chemonics. I no longer work for Chemonics. I work for Inward Development Africa Initiative. You know, because I work for an international organization, I'm called to be a member of the technical working group, whether I have the skill or I don't have it. But because I bear the name of Clinton Health Foundation, then I'm respected. Nobody is looking at the content, my skills, my experiences, but because it comes from an organization, it's an automatic member of the technical working group. And they come to the meeting not able to contribute to what is being said. So we need to start looking at criteria for selecting members into these committees that are meant to make a change or a difference in Nigerian health space. We need to conduct a theory of change for key stakeholders with specific criteria for selecting participants. By this one, I'm not looking for 80 people, because when we want to do workshop, we say everybody, carry everybody along. And so you have 250 people trying to develop theory of change. No, no more than 30. We have to say, these are the people from different areas, and then they sit down and look at, if change is to happen in Nigeria, what will it be? What color will it be? What shape will it be? How are we going to know it? But we need to make sure we start to ensure that people who are coming into these committees are people who can produce. The last slide. Hello? Am I still talking? The last slide?
Yes, you are still talking.
Okay, good. Thank you, sir. As a matter of urgency, we need to establish a highly competent team with clear work plans, specific roles and responsibilities to ensure the rapid implementation of the certificate of standards. Certificate of standards. It's not an easy thing to do, but we need to start them. And again, they should follow the pattern I've described about the coordinating team. Because we don't have a certificate of standards, some people, I'll give you an example of a friend who died in March. He went to General Hospital in Ikorodu, and the doctor was very nasty to him. He told him to get away. This person was a healthcare provider, unknown to him. And he said, I think I need ABC. He turned him out. He went to this hospital in Shagam and all that. He died 2 days later. I reported this case in Lagos. So people are still being turned away. We don't have certificate of standards. We have people who are practicing. We don't know whether they have the quality or not. It's not only patients that are running away and medical mission is still going on. Our doctors, our nurses, our medical lab scientists are waiting. They are waiting for the next. Everybody, you go to the embassy, you see the people who are applying. So we must ensure that, yes, the healthcare provision fund is bringing money, but we don't have standard. Nobody has a standard. How can we guarantee the standard? Develop and implement a peer review mechanism for state. People develop work plans. When NEPAD, the African Development Program, was when they had a peer review mechanism where countries will come back to another country and say, you say you were going to do ABC. Let's see how far. They visit and see and make recommendations. I think before the National Council on Health meet, there should be a peer review mechanism where states are paired together to go and review other states and come up with the report. And then another National Council on Health, you review whether they have followed it. Then the next thing is develop and implement a framework to harmonize country. Is to develop and implement a framework to harmonize country and donor operation plans. There are so many operation plans, but we have the National Strategic Health Development Plan. Which is the national plan? We have State Health Strategic Health Development Plan, which are state plans, and then LGA plans. So we should be able to coordinate donor funds, donor support into this national plan. We have one. Then the last one is develop a strategy for creating awareness, about the Health Act for health workers and the populace. How do we ensure that people know their rights? How do we know? People don't know that, yes, they could complain. They don't know that somebody could go to jail if they were turned back and all that. Some doctors don't also know their right, that the patients cannot do X, Y, Z to them. Finally, we need to strengthen the relationship between states and the Federal Ministry of Health. And how can we effectively use the Governors Forum? I'm sure the Governors Forum, my friend, is here. So these are the areas. There's so much, but within the time limit, I think this is where I will call it short. Check the next slide. I hope this is the last. Okay, discussion continues. Thank you. God bless you.
Thank you so much, Dr. Mike, for this brilliant presentation of the National Health Act. And as an addition, I just wanted to also highlight that recently the federal government passed the National Health Insurance Authority, the NHIA Act 2022, which builds on these reforms that the National Health Act has already envisaged. The NHIA Act clearly makes health insurance mandatory in the country. It also makes provision for massive coverage of health insurance for the vulnerable groups through what is called the Vulnerable Group Fund. This Vulnerable Group Fund also earmarks alternative sources of funding for innovative sources of funding for financing the Vulnerable Group Fund. This Vulnerable Group Fund through specific health insurance levies, donor funding, and also scaling up the basic healthcare provision fund. The National Health Insurance Act also makes provision for changing the nomenclature of the NHIS from to NHIA, and our executive secretary DG, and it also makes provision for a broader Reconstitution Act, also gives powers to the NHIA to regulate, coordinate, and integrate health insurance in Nigeria. As a step towards implementation, the NHIA has developed a very comprehensive roadmap. It's currently developing a very comprehensive roadmap for translating the National Health Insurance Act into an operational guideline, and that will guide the functions and operations of the NHIA and its stakeholders, leveraging on this act so that all Nigerians can have access to universal health coverage. Thank you so much, sir. The floor is open for comment, questions, and contributions.
Okay, the moderator, Dr. Awaka, could you also check the Q&A and chats for possible?
Yes, I've checked. I've checked that. I can I cannot see any comments.
Okay, there's Dayabu who has raised his hand.
Dayabu, please go ahead.
Yes. Thank you very much, Elder, for this very insightful presentation. Mine is just an addition to all the issues you have said, and then an additional recommendation. In as much as one of the biggest gaps in the health system is financing, which the new reform is addressing. But I think one of the major issues that is emerging now is issue of accountability. So much has been done through the NHIS and now NHIA to get the state to establish the state health insurance agencies. And so much resources is being channeled or pumped into the health system through that. The Basic Healthcare Provision Fund is also generating a huge amount of money. But the challenge now is that the increase in resources in the health sector are still not
increasing the health impact that we have because of issues of mismanagement and poor accountability along the line. So I think one of the recommendations should also include having both at national, at state, at health facilities, at all levels, proper accountability system that will ensure that as we are having more money for health, we also are having more health for the money. Otherwise, we continue to generate resources and the health indices will still continue to remain where they are. Thank you very much.
I think you're very correct on that one. Very, very correct, because the major problem we have is not, I mean, you listen to Dr. Kujo's presentation. Is somebody else, another country will take that presentation and run with it. For primary healthcare, we developed a management system for this country. In Yaba, it's working in Turkey. It's not working in this country. So I think it's an attitude problem. And a number of people go into sectors now, not what they will contribute, but the money they will make, the assets it will create for them to wealth or to move to somewhere they want to move to. So until we have to, we get some new generation of professionals, we need to start developing them. They will not emerge. They will not just fall from the sky. We have to be intentional in developing a new breed of professionals that will take over, because currently some of my generation, they are looking for money and nothing more. So it's something that we need to have. That's why I'm suggesting that strategic meeting where critical discussion will be made, critical thinking will take place, and then we look at each other's face and say, this is where we need to go. This is not good, this is bad, let's promote it. But here we need to involve, like this meeting, we should have, for instance, had somebody like a traditional ruler, because we're looking for support. The traditional institutions, religious institutions have large following, whether we like it or not. And so some of the politicians we have today emerge from them. They get blessings from traditional rulers. They get blessings from religious rulers. So they will be, so when they come back to get more blessings, they'll say, why are you not doing something about this health? And the person will listen. So I think we need to do more, and I'm encouraging people, expertise, PEEF, to engage more with those groups, because those are the people that can open doors. Thank you.
Okay, so there is a question from Adewumi Ayodele. Say, how does this idea fit into the current National Health Insurance Act? I think that has been answered in the sense that the National Health Insurance Act is actually leveraging on these reforms that have happened over time, and this is a foundation law for every reform in the country. Any other comment or questions? Okay, Ola Golden Semiyu, you mentioned that our problems have still not changed. It's still about people not being held accountable to what they are given to their responsibilities. And I just want to leverage on that to say that the BHCPF, both at the NPLCD and NHIA gateway, we are working, and even at the FMOH level, to develop a comprehensive accountability framework, that will guide the operations of the BHCPF at all levels. Yeah. So if there is no question, we can we move to the next session, or we'll take a break for 5 minutes?
Thank you very much, Dr. Kurfi, for moderating that session, and thank you very much, Dr. Mike Egbo, for that very detailed and comprehensive and enlightening presentation. We really appreciate the way the program has been put together. Actually, will not have any break. However, we'll advise that for health reasons, as much as possible, within your area, within your comfort, please try to take a few seconds to stretch while the program continues to run. But please do not leave us. Please, we'll soon be rounding up. I want to, there will be a slight adjustment in the program. We have reason to reason to do a little adjustment. And then the next paper will actually be the paper that is supposed to be at 110. We just have to oblige one of our presenter who has some time challenge. So I want to appeal to all other presenters and moderators to please bear with us while we call on Professor Ibrahim. Prof, sir, I can see you are with us.
Yes,
You will kindly be moderating the paper by Dr. Gafar Alawode on the National Health Insurance Act implementation for the vulnerable groups, monitoring and implementation. Please, I'll yield the floor to you, sir. Thank you.
Thank you very much, Mr. Moderator, and good afternoon, everyone. I'm pleased to be with you, though joining a little bit about a few minutes late. So thank you very much. I call on our presenter to please prepare his slides, and if ready, to just get on with it.
Dr. Gafar, please. You have to unmute yourself, sir. You need to unmute, Dr. Gafar.
Okay, sorry about that. And good afternoon, Prof, and good afternoon, everyone. So are you sharing slides from my end, or should I share from here?
From your end?
From your end, you should be the one to share your slides as you wanted to.
Okay, great. Okay. Can everyone see my slide now?
Yes, we can. Well, at least I can.
I can as well.
Okay, great. So good afternoon, everyone, and thank you very much for inviting me to make this presentation. I would like to thank the organizers for the great job. So I'll be presenting National Health Insurance Act implementation, the vulnerable group, the monitoring and evaluation. I've heard a lot of people that talk about accountability, and I'm very happy that I lead a sector reform coalition financing committee, which is working tirelessly towards putting together accountability framework for basic care provision fund. And of course, because the vulnerable group fund will be implemented through the basic care provision fund, I will be using the accountability framework that we've developed to have this conversation. So this is the outline. Of course, a lot of people have talked about background in terms of the country desire to achieve universal coverage, our struggle, the challenges, and the policy trust towards that. But I would like to quickly emphasize something and build on what Dr. Kufri has said. The National Health Insurance Act 2022 have some provisions which are extremely important. And for those of us that are doing health financing work, so towards achieving universal coverage, there are two extreme important conditions. And one condition is the mandatory participation in health insurance. Another condition is the creation of a pool fund to subsidize the poor and the vulnerable. So these two important provisions were catered for by the National Health Insurance Authority Act, and we are so excited that this is happening. In addition to that, of course, there are other important provisions like the recognition of the state health insurance scheme and description of a number of institutional arrangement and framework. So in terms of subsidization, the instrument of subsidizing 83 million Nigerians that are not covered by any form of health insurance is the Vulnerable Group Fund, which is part of the provision. And I guess what I'm asked to do today is to do the monitoring and evaluation. But I would like to look at so if we look at the Vulnerable Group Fund, there are quite a number of provisions in that Vulnerable Group Fund where additional money would be generated to pull the funds together and ensure that the poor and the vulnerable which have been put at around 83 million Nigerians are well taken care of. And it includes, of course, the basic care provision fund, which is already running. That's what they call health insurance levy. There's a special intervention fund, return on investment, grants, donation, gifts, and vulnerable contribution. But let me say that, of course, National Health Insurance Authority is still putting a lot of framework together to really prepare the details of what these things mean, and looking at what amount of money will come from each of them. But like I said earlier on, the vehicle for channeling them to service provision is the basic care provision fund. So when we talk about monitoring and evaluation, I want to look at it from the perspective of not only the monitoring and evaluation, including the accountability, because accountability is very, very crucial, and learning as well. And let me take us through why it is very, very important to have a sort of accountability framework and monitoring and evaluation framework. So we are used to more health for money and more health for the money. So for us to achieve more health for the money, for instance, we'd like to start from there. We have to be more accountable, because it's not impossible for two countries to spend the same amount of money and achieve results. And from the graph I've shown, you've seen each of the dots represent a country, and we are looking at the amount of money they are spending on health and the result they are getting. So you can see that, especially among the low spender, they can spend the same amount of money and get a wide range of results. But when it comes to even more money for health, Nigeria is not there. There's no point belaboring that in terms of comparing our health spending with a major benchmark. But again, why it's going to be more difficult is that the budget office, the Ministry of Finance, they don't think we're able to spend well. They don't think we're accountable. They don't think we have shown results for the money we have spent well. So all effort towards mobilizing additional funds, if you have not taken care of monitoring, evaluation, and accountability, it's not going to yield results. This is just by the way of background. And to tell us that even the money that is in the system, we are not able to show value for the money as we are able to. There are a lot of sources of inefficiency. We have problem of ghost workers, and we have the problem of commodity. We have the problem of having facilities that are not optimal in terms of how they are distributed, and many other causes of inefficiency. So, like I said earlier on, I chair the Health Financing Subcommittee of the Health Sector Reform Coalition, and we are saddled with responsibility of developing sort of accountability framework. We started even beyond accountability framework for basic care provision, but recently we are focusing heavily on accountability framework for basic care provision fund. And part of what we discover is that, of course, there are a lot of accountability framework in place to monitor, track what is being spent, and who is responsible for it. But what we needed to do then was to bring everything together, because if you look at the guideline for basic care provision fund, it actually makes provision for accountability framework as well. Some donors have accountability framework, civil society, and partners. So what we started doing was actually to bring, and even the various gateways, the National Health Insurance Agency, the NPAC, they have their own accountability framework. So what we started doing was to develop a citizen-led accountability framework, which harmonizes everything. That is what we've done. So in terms of the framework, so it actually covers a number of areas in terms of governance, in terms of funding, in terms of management, in terms of service delivery, and client satisfaction. And it is looking at accountability framework at community level, facility level, state level, and federal level. And each of we have indicators and their description and whatever. So, so part of what we are tracking at the governance level, because basic care provision fund, the governance structure is well defined in the guideline. So there are people, there are institutions like a ministerial oversight committee at the national level, the state oversight committee, and a lot of a structure that are supposed to be doing a number of things in terms of preparing work plan, approving it, looking at budget and all those. So we have a set of indicators that look at each of those areas. Are they being done? at the state level, federal level, at the state level, including audits of financial audit as well, to look at how much has been spent and to look at even the report of the audit, who is doing what with those reports. So we have a set of indicators as well. And then when it comes to program management as well, we have a set of indicators, including funding, to look at how much is allocated, how much is released, how much has transferred to the facility, how much has been spent there, and at the state paying the 25% counterpart funding that is expected of them. So we have a lot of indicators like that is tracking those. And in terms of program management, preparation of work plan, budget, and other program activities, so supporting supervision that are supposed to be conducted, are they conducted or not? And then again, service delivery is very, very important. It's not enough for money just to be moving from federal to the state and facility without looking at, is it leading to improved facility service delivery at facility level? For example, part of the indicator we are looking at our facility able to operate 24 hours because each basic care provision fund is working adequately. Our facility are supposed to have a good complement of our staff, commodities, and other things needed to provide 24-hour services. We look at some of the some services in terms of total number of people accessing the care. Is it increasing? What is this facility utilization in terms of consultation per person per year? We are looking like that and looking at some key services like skilled bed attendance, immunization, and others in terms of how we assessing those services. What is the benchmark? Where are we? What progress are we making? And again, it's not only about providing services. Client satisfaction is very, very important. So we have identified a number of our composite indicators that through exit survey, you ask patients whether, for example, what is the waiting time? What is the level of health workers' responsiveness? Did you get the drugs that you need? Do you still pay heavily out of pocket after receiving services as a basic care provision fund enrollee? And again, of course, even the community, what development committee want to get their perspective with regards to the quality of basic care provision funds. But what is actually very, very important is not only about collection of the data. So when we collect the data, it only tells us one thing, and that is transparency. We know something. But the questions about monitoring and evaluation and accountability is beyond just collection of the information. What we use the information for is actually more, it could even be more important than the information itself. So the theory of change, we are looking at, let's increase transparency. And when increase transparency, which is about to know, let there be answerability in terms of to act. What did we do with the information? That is what we are looking at. And in terms of accountability to change, what do we want to change? So we want to change something because we know something and we have done something. That's the basic and simple theory of change for the accountability framework, monitoring and evaluation that we are using. So in terms of to know, so what do we need to know? People need to be conversant with, of course, the basic things like rule input, but in terms of processes and the output as well, including the outcome, some of those indicators I've read out earlier on. So for example, we want to know how much money in terms of resources that have gone to the facility, what are they be able to do with it, what is changing in terms of number of pregnant women accessing care, number of children under 5 accessing care, is it low or high? But then the next question is that who needs to know? We have identified, of course, the citizen needs to know through the World Development Committee, policymakers, lawmakers, and the media. And how do we get this information? Of course, through data collection, process information, visualization. So what we're actually looking at is which we are piloting the use of a technology to collect data from facility using ODK, where we leverage on existing system like integrated supportive supervision. So when we collect the data, there's a server that everything comes together at the state level, at the national level, even at the facility, there's going to be like feedback to the facility, including community, to know what is the state of the implementation of the basic care provision fund. Then again, like I said, the next thing is that if we know, the next thing is to do. So the next thing is that as part of the accountability, what do we need to do when we get the data that facilities actually, for example, part of what we are saying is that the money is going to the facility, but utilization has actually not increased. We have people that have basic care provision fund cards, but they are not utilizing the services. What do we need to do? Engage the facility, engage the community to know what is happening, ask questions and seek clarification where necessary. And of course, we engage with various community in terms of what do we need to do. How do we do it? Of course, using a existing interface between community and facility to engage, using policy dialogue, engaging the House of Assembly where as part of their oversight committee to ensure that they are able to take necessary action, engaging the Ministerial Oversight Committee, State Oversight Committee to look at what difference do they want to make when they have seen reports and data from facilities in terms of basic care provision fund. Then we have to look at what do we need to change. For example, we want health indices to improve. We want funding to be well utilized. We want the system to be more efficient. Those are the things we really want to change as a result of the data that we've seen. Then who needs to change things? Again, we have defined in the larger framework the role of the citizen, the policymaker, the lawmaker, the media, the civil society in terms of what exactly do they need to do when they have the information about the performance of the basic care provision funds from facility up to the state level. For example, part of what we are tracking is that we discovered that in many of the states, the State Oversight Committee are actually not meeting. So, but nobody is taking action because nobody actually know which state is this happening. So if we know now we'll now be able to, call out the state that actually not doing what is actually needed. Then what would be the incentive for those changes? Could we have reward and sanction where states are actually performing, facilities are performing? What is going to be the reward? What's going to be the sanction? Both what is prescribed in the basic care provision fund guideline and other parameters as well. Can we have scorecard that compare the state comparison? Because part of what we know is that states in Nigeria are actually very, very sensitive. Governors are very sensitive to state comparison. So how do we begin to compare with one state that is performing well in terms of fund utilization, in terms of improving utilization of services? So compare them so that it will actually encourage other states to perform better. So in terms of next steps, we want to, of course, to do the validation of this mechanism. Of course, we are working with various gateways, a couple of which were at the MPAC day, and we're talking to the NHIA as well, so that to bring everybody on the same page with regards to this, so that we validate it. Then we go and do, pilot in a couple of states, and we encourage other states to take part as well, and fully deploy the framework so that we are going to not only having more money for health, so we'll be able to have more health for the money. So in my conclusion, raising the accountability bar is extremely important if we are going to make progress in terms of our SDG related objectives. Mobilizing more money for health and achieving more for the money will be more feasible if we raise the accountability bar. Take for instance, like I said earlier on, we are clamoring for budget office to give us more money. We are looking at a number of taxes that will be here, man. The budget office saying something. The health sector needs to show that they are very, very accountable and that we have demonstrating value for money. And then this framework we have adapted, we have developed, we hope it's going to help us in terms of raising the accountability bar for basic care provision fund. It's not only basic care provision fund, like we said, because the legal framework for National Health Insurance Act made provision for vulnerable health fund, where additional money will come and will be channeled through basic care provision fund. But if we're able to do this, we'll be able to encourage the budget office to do that. So and then effective the framework will require institutional capacity, strong leadership, and value orientation around the need for enhanced accountability in all sector generally, and health sector specifically. So thank you very much for listening.
Okay. Well, thank you very much, Dr. Gafar, for this brilliant presentation. I'm just looking to see if we have questions from the audience. I cannot see. So, gentlemen and fellow participants, we have listened to Dr. Gabar Alode on the implementation on the accountability framework for the vulnerable in the National Health Insurance Act. And he has brilliantly told us what the questions we need to ask, what we need to know, who needs to know, how do you collect it, how do we do it, and what do we do after collecting that information. He also led us into knowing what needs to change and who needs to change things. And how do we change things? And then how do we confirm that those changes had indeed taken place? So it's a brilliant presentation. I think part of our major issues in the country across all sectors, perhaps, is transparency and accountability. And I think this presentation sets the stage for us to ask the not so nice questions. Have we always been accountable? Have we always been transparent in our actions as we come along to implement, especially for the vulnerable, the National Health Insurance, National Health Act, rather. I would call for open questions if there are any, and written ones for those that wish to send a written question. The audience.
My hand is up. I raise
Okay.
my hand. Yeah.
Please go ahead.
Yeah, thank you so much, Dr. Gafar, for this very brilliant, I must say. I have two key concerns. One is the issue of what I call reality bar above normal. So if you look at the basic healthcare provision fund landscape, you will see the challenges of accountability are sometimes beyond the healthcare facility, beyond the level of even the State Ministry of Health, beyond the NHIA, MPSCDA, some high-level players in the states, for example, whereby you find a governor or somebody, and so our accountability framework should not be limited to healthcare facilities. It should not be limited to, it should actually be broad enough to really hold into account these high-level stakeholders who play a role in the implementation of the basic healthcare provision fund. I'm happy we have implemented for over a year or two, and we have seen some of the challenges that are happening. So we must devise mechanisms to ensure that we raise the accountability bar conventional. The second issue I wanted to say is what we have observed in the healthcare facilities and in some because of the basic healthcare provision fund. So before the BHCPF, our healthcare facilities were conventionally operating, a manual kind of system. But with the BHCPF, these healthcare facilities in charges have become managers of funds. They now need to know how to do balancing of accounts. They need to have some basic knowledge of financial management and the rest. So there are areas of what I call illiteracy that do occur, financial, that we need to really integrate capacity building as a component of accountability here. So we need to do that deliberate effort to build the capacity of our PHC in charges and other stakeholders in financial management, in claims management, and designing claims management, and a lot of other soft, when service delivery points as far as BSCPF is concerned. Thank you very much, Consumer.
Very much contributed. He raised issue on holding those on top, the political authorities, to be transparent and accountable, and also building capacity of operators at the lower level of financial management and how to balance a book when you get funds, to know that you also must account for those funds and how to account for those funds in a or should I say, in a professional manner. Thank you very much for that contribution. Any other one? Any other?
Prof,
Yes.
can I add one or two things to that? Can I respond to
Yes,
Dr.
please,
Kufri's comment?
Doctor. Yes, go ahead. Yes.
Okay, thank you very much. So, thank you very much, Dr. Kufri. I think you raised a number of very, very important points. Let me start with the second one with regards to facility financial management, because at times, you know, some of what we see may consider as mismanagement of funds as a result of technical capacity gaps. So, but I think there's a very good opportunity here, because I know there is IHP, USAID funded IHP is working with the National Primary Care Development Agency to roll out a set of toolkit and capacity building for, in charges in terms of facility financial management. So you're absolutely correct. Most of the people that manage that facility, of course, they are not trained in terms of managing money. They are only trained in terms of managing health facilities, but not in terms of managing money. So I think that area of intervention is long overdue. I think when NPACD rolls it out, I think all of us should support to ensure that that is cascaded to all the facilities. And then again, with regards to holding people in places of authority accountable, I think the starting point is the transparency. You know, if all of us know what is happening in all the states today, with regards to how much is going there, where there's mismanagement and everything, I think some of these leaders in the state want to be very, very careful to start with, because somebody is looking at the books and somebody is comparing. And then later on, I think basic care provision funds to be adjusted to ensure that to better reward states that are doing well in terms of getting results and managing resources very well, and so that to deter other states that actually have the tendency to mismanage the funds. I think those are the things I would like to say for now. Over to you, Professor.
Thank you very much for the response. I should have indeed asked you to respond to his observations. Thank you. Waiting for more questions or raise hands.
So I think there's a question in the comment in the chat box with regards to, if you want me to take it, sir, Prof.
Yeah, please take it.
Okay, so there's a question from Mohamed Adamu with regards to, he said, please, what are the existing interface between communities and the facility you referred? So I want to believe, I think part of the inbuilt mechanism for basic care provision fund and our system generally is the World Development Committee, which actually creates an interface between the community and facility. Of course, we have instances where World Development Committee themselves are challenges to the health sector. But at the same time, I think this is one of the interfaces that we can leverage to increase the interface between facility and community. And again, probably there are other platforms as well. If there are, town hall meetings and others, which create an interface between the government and the people. I think it should be a very good platform to discuss health issues. So those are the few things I want to say for now. Over to you, Professor.
Thank you. Any more questions to Dr. Gafar? Okay. Okay, Chair of the occasion, I think we have no more questions on this very important topic. I will ask if there are closing remarks from Dr. Gafar Alawade on this session that you wish to put forward.
Okay, thank you very much, Prof. I think, like we said earlier on, the issue of accountability, monitoring, collecting data, analyzing it is very, very crucial. And then it's going to determine whether or not we're able to mobilize additional resources, which we need to expand health insurance coverage to the 83 million people, Nigerians that are currently underserved. So I think all of us should pay attention to it and support efforts geared towards increasing the accountability, and all of us should be asking questions. Whenever we see the data, I think we should use the data to ask questions and not only waiting at the national level, even our various communities. When I go to my village, I go to the basic care protection facility, I want to find out the money they've received and what services are they providing. So if all of us are doing the same thing, I think we'll collectively contribute to raising the accountability bar for health in Nigeria. Thank you very much, sir.
Okay, thank you very much. I think there are still a lot of challenges in access for the rural and even the urban communities to access healthcare. This act is still very much constricted to a few, perhaps in urban centers and those in the formal sector. I could see the state governments are making strident efforts to roll out their own health insurance schemes, and it seems to be working for those in the government sector. That is those who are salaried and can make contribution directly from their monthly payments. But for the vast majority in the rural area and the vast majority of the unemployed, next challenge is how do you get funds released either by the federal government or NGOs to actually provide for their very basic health needs. We still have a huge gap. Like a previous presentation on the state of the PHCs in the country, I mean, I saw that only just about 20% are still functional. And perhaps those functionalities find that there are challenges for those workers to even provide the most basic for the citizens who are not earning. These are citizens that are actually just living, etching a living from the soil as peasant farmers or as just casual laborers, seasonal laborers. And they still have families, they still have children, they still have wives that are pregnant that need health care. So perhaps at another session, this organization, our organization, would address how do you transparently take healthcare to the very, very vulnerable, that are unemployed, and that majority live in our rural areas. I think this is a brilliant presentation, and I congratulate Dr. Gabhar Alawadi for this presentation. Accountability is so important, and I think it always makes a difference between our societies here in the sub-Saharan Africa and Asia and those in the Western world, where really transparency and accountability is assumed and everybody works towards achieving that. Thank you very much. We're done.
Thank you, sir.
Thank you very much, Prof, for moderating this session for us. And Dr. Alawadi, thank you very much. We really appreciate it. Once again, as we progress with the conference, I still want to advise that wherever you are, find time to stretch your legs. Don't sit throughout, because that is not healthy enough. Prof, will not let you go immediately. I think you will still moderate the next session for us. And that is the paper by Chief Mrs. Muji Makonjuola, MFR, Executive Director of International Society of Media in Public Health. Prof, once again, I yield the floor to you to moderate the session. Thank you very much.
Very much, Muji, and welcome to this conference. I have known Muji maybe 25 years ago or more, when she was still up and about at the Federal Ministry of Health, working for the NHIA, I suppose. And I one of those middle-ranking chief executives of a teaching hospital. So congratulations for the MFR, which I have seen added to your name. And I invite you to please prepare for the presentation. You will be the one regulating your slides from there. I will just be watching. Moji Makanjola, you are welcome.
Thank you very much, Prof, and very good afternoon. It's good to see you, Prof, after several years. and knowing that you're still very active in the, in this sector. Yes, should I, outline my slides from here, or am I getting that from source?
No, you are doing it. That is your slides, yes.
Okay, all right. I would show my face for a second, just to say that thank you for this invitation by the People, Expertise and Excellence Foundation. And this for me, it's exciting moment. I would have thought that initially I should, the paper presentation that I made was giving us a historical background really of where we are with the national health insurance. And well, I'm going to skip a lot of the slides that I've made and go back, because a lot of the presenters have spoken to some of the things which also I have tried to highlight. And I think we should not repeat that, so that we'll have enough time for discussion. Funding national health insurance for effective national impact is what I'm supposed to do. And you have there the outline, introduction, background, a brief on NHIA fund, the objective of the authority, which I'm going to skip because I'm sure we all know that, and source of funding for the health system in Nigeria. I think we need to remind ourselves with this, an impact of the NHIA funds, which is what we are looking forward to in terms of uniformity, in terms of equity, in terms of providing healthcare when needed for the Nigerian citizens. Of course, there are challenges, and challenges I'm going to be using the lens of the general view of Nigerians, because these are questions that we asked before we put this on paper, and of course, my conclusion. So let's go on straight to it. Quickly, I'll run through it. Well, the background. Health systems finance mechanism are critical in attaining a universal health coverage. I think we all agree. And this translates to citizens having access to affordable, available, and quality health services to reduce out-of-pocket expenses on medical services. We know that this is the real bane of the, of the society. Despite consensus to embrace and sustain universal health coverage, the dependence on out-of-pocket health payment as a means of funding the health sector in Nigeria is on the increase. And so this system of payment for health services impoverishes average health consumers, especially in low income and middle setting, where the majority of locals are unable to afford the healthcare services they required. I guess presenters before me had spoken to this, and so I would not waste our time with it. Seriously, in an attempt to address the lack of financial risk protection, the federal government of Nigeria in 2005 started the National Health Insurance Scheme with NHIS, we'll remember, with the aim of providing access to good health services, also to ensure the protection of households from financial burden of out-of-pocket health payments. However, the quest for an alternative formula for funding free health services for all Nigerians informed the provision of the National Health Insurance Authority Act. And this is where to go, and hopefully praying that this will be implemented to the letter. This act was signed into law on the 19th of May, 2022 by the President of the Federal Republic of Nigeria. The new law repeals what we had before, and we hope it will ensure the effective implementation of the National Health Insurance Policy that ensures the attainment of universal health coverage. So I'll move on to because we all are very familiar with the objectives of the authority, let's speak seriously to what it concerns, source of funding for the health system in Nigeria. Over the years, since I have tracked and be able, reported and spoken to sources of funding for health systems in Nigeria, we know that On top of it all, on top of that bar, is out-of-pocket payments. This is regarded as one of the most utilized means of accessing health services in the world, not peculiar to Nigeria, but generally something that we need to focus on in this country. It is a payment for healthcare user fees at the point of service. Oftentimes, according to the World Bank, the number of poor persons in Nigeria was projected to hit 95.1 million in 2022. And yet over 70% of health payments are made out of pocket in Nigeria. This over-reliance on out-of-pocket payment could result in astronomically increase in the poverty levels of the country. Because if you have to pay out of pocket, a lot of times you cannot afford it. And that's why we still have all the high incidences of morbidity and mortality in our country. So let's look at sources of funding for the health system in Nigeria. Tax-based revenue, health financing system, where government revenues are the main source of healthcare expenditure. The funds are generated from internal revenues, from crude oil revenues, taxes, levies, etc. Now, there are newer options that are coming. These newer options of tax-based revenue being proposed, the sugar taxes from sugared drinks and beverages, tobacco taxes, communication taxes, IT apps launch and usage taxes. Well, these are the new ones that are coming now, but how soon they will crystallize into what we need to use as source of funding for the health system in Nigeria is something new. Social health insurance. Healthcare needs are very unpredictable and unaffordable for some individuals. A mother in labor at any time of the day, the child does not give you, doesn't say, I'm coming at so day. So if it comes at the time you need to go, then maybe you can't afford it. Hence the need for social health insurance. That's speaking to maternal health. Now, looking at children or looking at the most vulnerable themselves, or even individuals, the COVID times have taught us that diseases don't give notice. They come at when they want to. So this is a system of financing care through contributions to health insurance fund pool that operates within the framework of government regulations. This will decrease the financial load of out-of-pocket healthcare services on health consumers. At the very beginning of the national health insurance, we the only federal civil servants enjoyed some measure of social security funding. Now, donor funding. Financial assistance is obtained from donor agencies, individuals to support healthy development. The support can come in form of aid grants to finance health programs that we have. This new thing that is coming up now, which we call the Private Sector Alliance of Nigeria, adopt a PHC in Nigeria, targeting the 774 local governments. Some individuals, the likes of Dangote, Lumelu, and Ovie, have been able to adopt their own communities. I've been made to understand that, for example, in Kano, Dangote has adopted all the local governments where, to ensure that some measure of insurance is given. So community health insurance, run insurance, several already in existence. Also, trade groups can, aggregate their own funding for ensuring members' health. The private sector, I think, have done well with this in terms of providing health insurance for their workers. So private health insurance is directly and voluntarily funded by prepayment to insured members. This is when employees of an establishment receive medical care from stipulated health facilities at the cost to the employers. So pooling arrangements. Pooling is essentially the mobilization and management of healthcare revenue for the population, ensuring that cost of healthcare is distributed amongst all members of the pool. One major means of pooling is through health insurance. Pools can be based on compulsory, automatic, or voluntary participation. The case, I would like to use here is government, for example, at the inception of the national health insurance, where federal civil servants enjoy, budget allocation. We have the basic healthcare fund, which a lot of us have spoken to, particularly presenters before me, and I would not want to go back to this. Now, community-based insurance. Well, we have the Shonga experience to look at. The Shonga experience is the one which I have tracked, which has helped. This method of financing is designed for people living in low income settings. The mechanism allows households in communities to voluntarily fund or co-fund the cost for giving set of health services. Participating in the management of the community financing system, there are already communities who fund their own health by contributions and assistance. E.g., we have, well, I was told that we have some in Sokoto, but one that have followed through and that is still working and functional, it's the one we have in Shonga in Kwara State. So these are areas of which we can source or ensure that health insurance comes in, and to limit as much as possible out of pocket expenditure. Now, impact of national health insurance funds. The impact is enormous. It will avert the impoverishment of health consumers because of enormous medical expenses, particularly when things happen and people don't have the money to fund their health. Additional funding for subsidies will increase general government expenditure on health. Improve the health status of citizens by ensuring financial access to essential public health services. Aid the effectiveness of healthcare delivery service across board, because with the availability of the funds, we hope that facilities would be better, the standards of the resource persons also will be better, and services provided, of course, will improve. National Health Insurance Authority funds will create a vulnerable group, which fantastic. I think this is, for me, the take. It's the cake, is the icing on the cake for the new National Health Insurance Authority, which has been rolled out and signed into law, because it will subsidize health insurance of vulnerable groups and the indigents. And these really are the victims most of the times for out-of-pocket expenditure. Reduce mortality, morbidity in vulnerable populations, direct impact of improvement of the NDHS performance, and in the long term, improve life expectancy across the demographics within the country. Still on impacts of National Health Insurance Authority funds, ensuring financial protection for health consumers. That is, no household spends so much on health that it falls into and cannot overcome poverty, especially when you have long-term illnesses, like take, for example, cancer. It impoverishes everybody, whether it is directly or indirectly. You find out that you have to contribute, and that's why you have most of the times, particularly these days, the social media is clogged with, knocking on people's doors for intervention for people with who needs critical care. Higher collection of premium contributions through enrolling new members from the informal sector, and compulsory membership of the NHIA with subsidy for the informal sector and the poor will lead to higher population of coverage. So how do we consolidate the impact of these funds? It will be narrowed down to improvement in National Demographic Health Survey, upgrade the nation's ranking from our terrible poor position from almost the bottom of the global index, even as we speak. Free up out-of-pocket cash expenditure for family income and other sectors that will better perform for development. It is a research fact that working Africans support about 12 family members. You find out that there's no day that you won't get an alert or a request from a friend, from family members, or wanting some measure of help. And this impact, of course, impoverishes not just the sick, but of course, also you who is helping to help. Lesser impact will undergird social support for improved social economic outcomes and less malnourished children. It is a health economic fact that malnourished children respond less or do not even respond to vaccines. So more prone vaccine preventable diseases. So the nation is still at a risk of their groups. Overall, life expectancy improves across the various demographics. Even the very, very affluent is positively impacted since they too live longer with vulnerable health funding. Educational levels, hopefully, will improve since out of school times are significantly reduced. We have a healthy herd of more young Nigerians who will be able to stay in school more often. Higher productivity levels across the national demographics since downtime from work for hospital visits are drastically cut. And we find out that especially with the diseases that we still, and illnesses that as a people we still have to cope with. We're still talking about malaria and the impact and other, in that line, we're speaking of non-communicable diseases as well. And I'm hoping that when we consolidate impacts of NHIA funds, this will help higher GDP nationally and greater prosperity for the country. However, there are challenges, and we need to speak to these challenges. And I think this is why PEEF must be one of the reasons why we're speaking to financing health and making it a health security, as I would want to put it. Now, national health insurance is a relatively new concept for us in Nigeria. So the concept is being grappled with across all spectrum of society. The challenge of trust, an inherent abuse of trust embedded in the system for dearth of integrity within society and health facility operators and users. Even in the developed countries, this element of trust exists, however, to a lesser degree. When we are talking of trust, you find out that because Nigerians don't even trust in the health system now, they'll seek other alternatives. Suddenly, we'll find out that these alternatives, when they get worse, they still bring them back to the hospitals and all that, but they shouldn't have. And so more money is spent, and these, of course, will challenge the National Health Insurance Authority funds. Now, the term insurance in this climate neither engenders trust in the operators nor government, where huge trust deficit exists. And this we need to address. I hope that I'm happy that Dr. Kofi is here. And these are things that we need to address for people to want to embrace the funds that will accrue as a result of the National Health Insurance Fund. Another is widespread illiteracy. A lot of people do not yet have an understanding of what the concept means for them. There's need for us to create an aggressive awareness for people to understand, so that people can have the buy-in of people, because this is a people-oriented intervention that we need people to buy into. So we need to go on aggressive awareness across board, making people to understand how it works, how it will work, and what are the benefits inherent in it. Low enrollment figures because of low awareness threshold. Need to drive enrollment as a fallout of the above points by creating awareness on the benefits of health insurance at all levels. It should be at all levels. Availability of facilities meeting up with the expectations of the enrollee. A lot of people have spoken to it, and I think Dr. Gafar and Deacon Michael spoke to this extensively. We need to galvanize availability of facilities and make our facilities attractive. And I think the very first presentation, Dr. Kojo also made, in fact, he brought it to life, the pictures that he showed. These pictures are just not, they're not archival materials. They're still there today. And again, we need, there's need to be a synergy in the provision of facilities, so that facilities are within the benchmark of what the alma mater says, where people can access it and where we can create demand, which also I'm sure will ensure that people use facilities. Then we must guide against abuse as occurs in other countries where it is not contributory. It should be contributory to enhance its value to users, because abuse is inevitable where value is not realized. This, I would like to say, cuts across not just in terms of the people, the users themselves, eventual users, but of course, the professionals themselves. We must have more friendly, facilities that will help bring people in without going to seek for other alternatives, which eventually we continue to hype the prevalence of morbidity and mortality across board. In conclusion, the National Health Insurance Funds, if properly applied, has an undoubted multiplier effect on the national life. It has a concentric effect on the life, occupation, peace, social, economic, prosperity, education, and growth of the nation. And I dare say, before I wrap it up, that of course it must also give security in these times where we're not sure about security. I think security should also be part of the concerns that will ensure the impact of a national health insurance fund. The population can now devote more time to developmental issues. And so the quality of life and strategic health of the nation improves in the long term. This is something that we must pursue vigorously going forward. And for me, this is the way to go if truly as a nation, we are serious about attaining the universal health coverage. I thank you for your time and attention. Thank you, Prof. I yield the microphone to Prof. Thank you so much for listening.
Very much, Muji. As usual, we're highly impressed by this presentation on the impact of the NHIA funds on overall. She has touched actually on all sectors where health, all sectors of health and even beyond, on our economics, our well-being, and now finally even on our security, which of course is now on the front banner across the country. I'd imagine participants would have questions, or either written, or those who wish to raise their hands and ask questions directly to presenter. She addressed NHIA Act that has replaced the NHIS Act, spoke about the out-of-pocket expenses and the huge amount of poor and vulnerable that this country has infamously now taken the lead from India, of about 95 million sown. And then the sources of funding, she discussed that, the unpredictable nature of insurance, and where money to support healthcare for the poor and vulnerable may come from, and various categories of sourcing of funding. On implementation, she spoke about newer concepts on upgrading and freeing up the out-of-pocket expenses to allow families to devote on their own nutrition, their clothing, and their other needs. How that will impact on our overall life was also discussed, including having less malnourished children, having longer life expectancy, and having more funds to fund education, which increasingly has to be funded by families, and eventually leading to higher productivity. So it's a new concept. She discussed about the challenge of trust, which again will rhyme with the previous presentation by Dr. Gavara Lodi, transparency and accountability. This also has come forth in this presentation, trust. So we have to look inwards as we discuss this paper on how, and the previous one on how else, or how we could improve our overall transparency and accountability as groups, as individuals, and as a nation. Widespread illiteracy, I think this applies more to some zones of the country, like where I come from, than some other zones that have actually reached very admirable levels as far as literacy is concerned. The low enrollment figures. What we didn't harp on is, seeing Nigeria as one single group with the same dynamics. Actually, some of the impact of lack of health cover is more felt in some zones, particularly if you read the statistics from the National Board of Statistics, NBS, or the inputs from foreign, NGOs, or even from institutions like the BBCs. The impact of inavailability of healthcare and poverty is more felt in our zone in the Northeast and Northwest in particular. If you check the statistics, the maternal mortality, if you see the national average, you think, well, we are going somewhere. But if you look at the zonal averages and compare some zones with the others, some zones are already at the level of Korea and South Korea and Malaysia, whereas our zone is at the very bottom of the world. So it's also things that NHIA has to look into as it bundles. I would ask for questions to the presenter, and also contributions, either by way of raising your hand or by writing the question and sending it across. Thank you very much, Situa. Any hands raised? I haven't seen any.
I think. Yes, I think there's one hand up, one Maria Mohammed. There's one Maria Mohammed, her hand is up.
Please, Mariam, can you come on? Can you come?
Miriam, you have to unmute yourself. Unmute yourself and speak. You are muted, Miriam. Well, maybe we can, Prof, maybe we can proceed because we're actually running out of time.
Yes. Okay, any concluding remarks? Moji, any concluding remarks from you?
Thank you very much. I do hope that some measure of impact has been made with the presentation. I've enjoyed, I've enjoyed every moment here. This is something in the works that all of us must embrace, and I hope that we'll be able to give it some measure of, publicity in terms of awareness going forward, because that's my own terrain. I believe that a lot of awareness needs to be created going forward so that more Nigerians can embrace the national health insurance. Thank you for listening on. Thank you, Prof.
Thank you very much. Thank you very much. So we come to the conclusion and the end of presentation from Moji Makanjuela on the effective impact of NHIA. So this session comes to an end. Over to you, our chief host.
Thank you very much, Prof, for moderating those two sessions back to back. I really appreciate that. And thank you very much to Chief Mrs. Makanjuela, MFR, for that very enlightening presentation. We really appreciate. We're running out of time, but we have just one more paper And I want to call on, this time around, I think we'll just go straight and moderate the session. I'd like to call on Dr. Patrick Correa. Patrick Correa is the Managing Director and CEO of Sunu Health in Lagos. And then he'll be speaking to us on the role of the HMO in the National Health Insurance Act. Dr. Correa, please. You may have the floor.
Thank you very much. I shall be speaking on the role of HMOs on the National Health Insurance Scheme. I'll pledge that I maintain the existing protocols since we have really run out of time. My presentation will have the following outline: introduction, objectives, definitions, HMO under the NHIA Act, the role of HMOs, then conclusions. As you all are aware, the National Health Insurance Act 2022 replaced the National Health Insurance Act (GAP) and 42 laws of the Federal Republic of Nigeria. It was this previous act that the health insurance scheme in Nigeria has been running. And the main essence of this new act is to ensure effective implementation of the National Health Insurance Policy that can ensure attainment of the universal health coverage in Nigeria. This act that is to ensure universal health coverage in Nigeria also went further to redefine the whole roles of health maintenance organizations who have been underwriters of health insurance in Nigeria. Because earlier than now, the HMOs have been the major underwriters, the only underwriters of health insurance.
Please, Dr. Corey, can you put it on slideshow? Presentation mode.
Okay.
Thank you.
Thank you. Okay. So the objectives we'll tend to achieve at the end of this presentation shall be for us to define a HMO, differentiate the roles of HMO under the private health insurance plan, the federal health insurance schemes, and under the NHIA Act. And we may be able to also, at the end of this presentation, enumerate the rules of a HMO under the Act. HMO is a medical organization that provides health insurance and medical care to those who approach them for health insurance coverage using accredited group of healthcare providers. This a general definition of HMO. The HMO is also an underwriter of health insurance. HMO also offer prepaid healthcare schemes. A HMO plan requires that a beneficiary should first access care through a assigned provider called primary care provider. And the primary care provider may refer to another level of care, secondary care, if there is need. The primary care provider in a HMO system serves as a gatekeeper. And in Nigeria, HMOs provide private health insurance plans. Under the NHIA Act, HMOs are described as a body, corporate, as a limited liability company under the Company and Allied Matters Act, and accredited by authority as a health maintenance organization. So if an organization is registered according to the laws of Nigeria and is not accredited by authority, is not yet recognized as a health maintenance organization. And the organization must also comply with the provisions of all relevant laws in Nigeria. Then the Act talked of health management organizations. In the section where I start talking of accreditation, talked of health management organizations. A health management organization means an organization that provides or arranges for insurers, individuals, and other entities on basis of prepaid contractual arrangements. This may include health maintenance organizations. So a health maintenance organization is a type of health management organization. There are other kinds of health management organizations, but the Act spoke about health management organizations when they were talking of those to run the scheme. Then the accreditation of health maintenance organizations shall be according to the guidelines set by the authority. But one condition that is new for health maintenance organization in this Act is that of security deposits. The private health scheme or plans are required as a condition for registration by the authority to deposit with a bank accredited by the authority an amount of money in an interest yielding account that shall be prescribed as security for its members. This is one of the new conditions for a HMO to be a HMO under the Act. Let's quickly look at the rules of HMOs under the Act, because one of the first things we say the HMOs are underwriters of health insurance, who've been underwriters of health insurance in Nigeria. The Act also specified that, and one of the primary rules will be to cover interested individuals, employers or employees of organizations in the private sector who may buy the scheme for supplementary benefits. Though the Act under Section 3C mandated the authority to that basic minimum package of health insurance, to integrate basic minimum package for all Nigerians across all health insurance schemes. The Act established health insurance schemes, which included private health insurance schemes. And the Act said that the authority is to integrate this across all the schemes, which includes the federal, state, federal capital territory, as well as these private health insurance schemes. So basically speaking, the private health insurance schemes can actually underwrite the minimum basic package as part of their package. But we do know that private health insurance is not a favorable pathway for attainment of universal health coverage. So if the essence of the Act is to ensure attainment of universal health coverage, the ideal thing is for the basic minimum coverage to be provided for all Nigerians under a social health insurance system, while the private health insurance schemes provide supplementary health insurance on top of the minimum basic package that should be available for all Nigerians. This basic minimum package should be available for all Nigerians, not a limited people. So private health insurance scheme can only provide this supplementary package on top of a basic minimum package. This is the only way we can use health insurance to attain universal health coverage, and then private health insurance scheme serves as a supplementary. In a system where we don't have mandatory health insurance or a package aimed at towards universal health coverage, private health insurance schemes are the vanguards. That has been the situation in Nigeria. Earlier than now, private health insurance scheme came into force before the national health insurance scheme, and they prepared the ground, providing end-to-end health insurance, but the new act have now made it in such a way that they take their roles as supplementary schemes, while a general scheme for all Nigerians that will be underwritten by the authorities and state health insurance schemes come into place. But in section 34 of the new act, more roles are enumerated for health maintenance organizations. The first thing that's written there is that health maintenance organizations will have roles as may be assigned to it by state health insurance schemes, including that of a third-party administrator. It is the state health insurance schemes or the federal health insurance that will assign roles to health maintenance organizations. We know that states are mandated to establish and implement health insurance schemes for purpose of covering their residents. They can select health maintenance organizations, the act stated, where they do not have their schemes. Health maintenance organizations can underwrite the health insurance for them from end to end. But where they have a scheme that they've established their scheme by law of the state, they can appoint health maintenance organization to perform other functions they may assign, which may include that of a third-party administrator. And they may also be employed to collect contributions and ensure prompt remittance of contributions to the pools, either the state or national pool. And they can also perform other administrative charges to the authority for purposes of regulation. One thing that is of interest in the new act is that health maintenance organizations shall from now pay for services rendered by healthcare providers accredited under the scheme for health insurance, for private health insurance. HMOs shall no longer be paid for fee for services rendered under the state or the national health insurance scheme. This means that health maintenance organizations are no longer the risk bearers, underwriters of this scheme, which had been the case because the health maintenance organizations have been the risk bearers of all the formal sector social health insurance scheme in Nigeria. They've been the major underwriters paying for fees for service, whether the funds are sufficient or not. As they pool, they have done it, they take the risk. They've been the major risk bearers. And with the new act, they are no longer the risk bearers. They shall only bear the risks for private health insurance scheme. One other role that the HMOs you are playing before that are still going to play now is to establish a quality assurance system to ensure that quality of care is given to enrollees by the providers. The quality assurance evaluation of the scheme and provision of quality assurance services is one of the roles and functions of health maintenance organizations. It was in the old act, and in the new act, they're still going to perform those functions. And then they must render to the authority returns of its activities as may be required by the council, and perform any other functions and may be determined by authority. So the functions of the HMOs have not been exhausted by the Act. So the authority may assign other roles and functions to health maintenance organization as the need arises, because they will generate the operational guidelines that will define more the roles of health maintenance organizations. And they will from time to time review these roles to ensure proper implementation of the Act and our attainment of the universal health coverage. In conclusion, under the new Act, the HMO is to underwrite only supplementary private health insurance scheme, except if authorized by a state to underwrite state insurance schemes. This may apply to states that have not yet established their health insurance schemes. They may employ HMOs to underwrite the schemes for them. And HMOs also has to function as third-party administrators, provide quality assurance services, and HMOs shall also be assigned roles by the federal and state schemes, apart from those stated under the Act. So we're expecting a situation where the state health insurance schemes, the federal health insurance schemes, by the time the operational guidelines are released on implementation of the Act, to define proper rules for health maintenance organizations, apart from that of third-party administration and any other rules and quality assurance, so that health maintenance organizations will continue to play their roles in ensuring that you have health for every Nigerian, and we attain the universal health coverage. Thank you very much.
Well done. Conference Chairman, your turn.
Chairman, Dr. Shagu. Okay, thank you very much, Dr. Patrick Curry, for that very illuminating presentation. So let's take any comments or questions that the delegates have. Dr. Curry, can you also check the Q&A for any questions, or the chat box for any comments that you need to respond to by clarification?
I think the questions there, there's none in the chat box so far.
Okay. Well, in that case, if there are no comments, I thought Engineer Blabuka wanted to make an intervention. Hello? Okay. All right, so no further interventions. Thank you very much, Dr. Patrick. We really appreciate your presentation. You may stop sharing your screen. Okay, so we are getting to the end of this conference now. And the next thing is our usual tradition at PEEF to focus on actionable points. And we would like to share with you what we have heard and get your validation as we prepare to put those into a report, which will cover the communique, but also specific action points to follow up with stakeholders. To do this, is one of the planning committee members, Mrs. Jacqueline Money. So, Jackie, if you are ready, would you be able to share your presentation? Can you unmute first? Because you are not, okay, good. So if we could start with the first, the opening session, and then we'll go to the presentations. One or two actionable points that you have noted, which we need to follow up with in terms of how do we move the dots beyond this conference? Who do we engage among the key stakeholders in the public and private sector? So over to you, if you're ready, Jackie.
Good morning and good afternoon to everyone. I will continue with the existing protocol. It has been an interesting time for me, and I'm sure based on the chats we've been receiving, everyone has had, or most people have had a wonderful experience. And we started off the 6th conference with our BOT chairman, who welcomed everyone and went on to outline the purpose of PEEF. He also then told us that the purpose of PEEF is an opportunity to which actions to ensure effective and tangible achievements in improving, especially for the 6th conference, in which action will be galvanized to ensure effective and tangible achievements in improving the health system and upgrading the quality of life across all strata of society. The goodwill message was given on behalf of Dr. Sambo by Dr. Ike Jonathan. And his own session too was quite enlightening, in which he outlined that there is a 10-year strategic plan in place, and then the coordinating framework with stakeholders. And they have developed a system for integrating groups and individuals that were previously not captured in the previous NHIA plans. He also told us that they're working towards the digitalization of the health sector. And he, told us who the NHIA, as in their responsibility as promoters, regulators, and they are the ones who integrate the provision towards a better healthcare system in the nation. After his goodwill message, we then went on to our first paper, which was on the role of the primary health care in universal health coverage. This was given by Dr. Ngozi Nwosu on behalf of Dr. Fastia. She outlined that they support the delivery of primary health care in Nigeria and mentioned the challenges in the healthcare as high mortality rates, which led to the introduction of the universal health coverage with regards to women, pregnant women, teenage girls, and children. She also pointed out that most of the payments for healthcare in Nigeria has been out of pocket. And that's also is one of the themes that one of the targets for the introduction of the scheme, which is also where we now talked about funding. Most of our papers, our subsequent papers, talked about funding as to how to ensure the amount paid by healthcare enrollees were not in such a way that their pockets, what they have, will be depleted by having to take care of their health. She also now talked about the framework, which is the financing, service, equitable preparedness, and governance, with a yearly scorecard by which they would know and measure their performance. The issue of poor infrastructure, which is caused by financing, is also being looked at, and she beckons on interested stakeholders that they are meeting with stakeholders to help ensure that some of these infrastructures, the poor infrastructures, are a thing of the past, and to improve access to health facilities by citizens of the nation, and then promoting partnership, and then scale up innovation methods by technology and in the collection of data. After her own paper, we now went to the other paper, which is the NHIA as a transition to universal health coverage, the imperatives. The challenges looked at is how UHC will be funded. So as we said, funding is one of the basic challenges, which is what we at PEEF would be looking at, because even though with some other papers, we talked about how it's universal coverage will be met, but how to implement it, because we talk about having policies, but the implementation and its challenges are things, as Dr. Egbon is passionate about, is in its implementation, because we have so many policies on ground, so many frameworks, but if you do not have the right people in place, I'm sorry, I think because of time, I'll just summarize.
So
summarize, because all the ideas.
Yeah. Just one or two bullet points about on each paper, so that you have 3 minutes to do that, so that we can move on to the closings.
Okay, talking about the imperatives. Yeah. So we talked about, getting registered enrollees, ensuring that everyone is enrolled. So if you have a cell phone, by implication, you are
okay, we're having connectivity
enrolled if we take.
Okay.
Yes, Dr. Charles, he was the one that talked about the health bank, that if you have a cell phone, by inference, you are enrolled, and if agreed on, by your subscription on a daily basis, 20 Naira is taken to fund the pool. And from there, you can go to a health center and you will be attended to. You do not have to pay out of pocket. Dr. Mike and a few other attendees mentioned that there needs to be a change of attitude by citizens, which is also something Dr. Chief Mrs. Moji also emphasized on, because of the issue of trust in the insurance, by the term insurance, and integrity of the nation. That there has to be education of the citizenry and those who are called to be in charge of the health care system. We now what's it called? Yes, we now talk about training of the matrons, because they are the ones in charge of the immediate primary health centers. So if we train them, because you are supposed to graduate from the primary health to the secondary to the tertiary. So if they are trained, they do the basic things, because doctors, as we're told, are not the ones who are supposed to be in charge of those who come in first at the primary level. So you train the matrons, you train the nurses, and then we have the youth corpers deployed to the rural areas, so that with experience and with all that, they do what they are meant to do before they are now sent to the secondary and then the tertiary. And then with the feedback process, they now will refer them back to where they're coming from. Then we talked about the implementation
Jackie,
of the national
Jackie, I think we need to wrap up now because of time.
Okay. Yeah.
Yes. So we're going to put this together very well after this session. So thank you very much for taking us through this session. We really appreciate the points you have shared with us. We also invited, based on the engagement we have with Deacon Mike Egbo, Dr. Shehu Sule, who's a subject matter expert on health matters, and he has been with us since the beginning of this conference. And I just wonder if he has any comments to make. He's been quiet. We also invited Dr. Alima from Katsina, who has also, these are all subject matter experts on health matters. So, as well as the Emir of Sunga in Kwara State, who is a medical practitioner by profession, but a traditional ruler, and also a very passionate individual with regards to the issue of health here in Nigeria. So if any one of them, particularly Dr. Shehu Sule, who is, I think, is still with us, would like to make any comments, please, this is a moment before we close this conference. Okay, all right, so silence means there is no intervention from any of them. The VOT chair, is there any final comment you would like to make before I do the closing?
I thank all who have participated in this event, from the beginning to the end, for the excellent papers we have listened to. Even I, a non-health professional, can still follow every dive as we go through, and for the potential solutions that I see that will come out, not only for help the health sector, but also helping many other sectors in the Nigerian economy. And I thank the organization for the ability to produce such passion and to bring such subjects that cuts across so many things and to enlighten. I've learned a lot of things now that probably reading the acts before the event didn't allow me to understand. Now I understand it a little bit better, and I can see what we are going to do. I hope we're going to have a straightforward communique, which will be able to try and find a platform to see some of the people who are here, so that we'll go and try and make an advocacy case, both within the government and the legislature, so that we have got a way forward that can be implemented and that can help the basic sound cause for which it is established. So, Conference Planning Committee Chairman, thank you very much for your efforts. And to all the presenters, thank you very much. We appreciated your scholarship and your perseverance and your brilliance in delivering what we have. To the moderators also, who kept it live and kept everybody ready, we say thank you very much. So over to you, Honorable Secretary, for the rest of the members. Thank you.
Okay, thank you very much, BOT Chair. You have, in a way, done my job already, the both of that. So, but nonetheless, I would still like to add that this is our 6th annual conference at PEEF, and it's been a long journey since we started in 2017, as the BOT Chairman presented in his opening speech. We are a non-profit organization. We are not funded by any development partner or government or private sector. We tax ourselves. We are professionals across different value chains of the economy, from engineers in petroleum engineering to accountants, to legal practitioners, health workers. And over these years, our colleagues in the health sector, the doctors have been very passionate. So we are focused now twice on health matters. In 2019, we focused on universal health coverage. And Dr. Kuju, who presented today, also presented that year. I think similar, is the same proposal, but now enhanced. And our communique was actually submitted by Chairman of BOT to the Minister of Health, Dr. Hanire. So we believe in a way the outing we had in 2019 had some input into the National Health Insurance Act. Conference really towards how do we get implementation to be right on our journey towards full, universal health coverage. It's an improvement that there is a focus on the vulnerable group in this act, but that's not the bus stop. We need to have 100% full universal health coverage. So on this note, once again, we just want to appreciate the speakers, the speakers who, some of whom really, we appreciate their time, short notice. We have Professor Sambo himself, who couldn't make it, gave us a very, very inspiring good message. Dr. Ngozi, representing Dr. Faisal Shoaibu, again, very, very brilliant presentation, touching on policy and practical issues in terms of the primary healthcare delivery. Dr. Charles Kujo is a member of PEEF and is very passionate about this subject matter. We thank you very much. Deacon Mike Egbo, we thank you very much for your passion and for the insights why things need to change from the people's side, the quality of the personnel, the commitment, and all of that. Chief Mrs. Moji, thank you. You have been a veteran in health matters right from your days at NTA. We are happy that you have made it at this conference. We really appreciate you. Dr. Gafar Alawode, is a guru. He's been very, very known in this area. We really appreciate your insights, particularly the issues around transparency, accountability, and of course, consequence management. We need to hold people accountable. Dr. Patrick Kore, you were with us last year as a presenter, and again this year you have obliged us your presence and your talent and experience in the industry. We really appreciate you. We also appreciate all our moderators, some of whom actually we got last minute, very, very short notice. So Dr. Charles Kujo was billed to be a speaker only, but he also covered as a moderator. Dr. Ramoto Hassan came in last minute because Professor Abdullah Abba, her husband, couldn't make it, conflict of appointment, so we appreciate her as well. Dr. Kufi Abubakar, we thank you so much. Professor Ibrahim, thank you so much. You did 2 sessions back to back. We really appreciate you. In spite of the fact that you joined a bit late, but we really appreciate that. And of course, I hope I've not missed out anybody. Yeah, okay. We also appreciate the planning committee. Dr. Musa Shaibu has had a very challenging year, I should say, because in the course of this conference planning, he became bereaved. One of his beloved sisters passed on. And that really was very tough for him, but we thank God that he's been able to pull through that. We pray Allah to repose the soul of his sister. Members of the committee, Mrs. Jackie Money, thank you for dedication and selfless contribution. Yusuf, Umar, thank you so much. And Adeola Adikbege, you are here today. We thank you for your contribution. Thank you, everybody. Of course, the BOT chair, we cannot thank him well enough. He has been there from the beginning, always there, opening our conferences, but also giving us financial support. He's done that over the years. So, sir, we really thank you for being there. We believe at PEEF that we are really adding value. We are not a political party or a partisan group. We believe some of us are retired but not tired. So giving back to society through this kind of activity is what we think we should do. It's not enough to criticize government and give up. We can't give up. This is our country. So we have to do what we need to do to move it forward in whatever way we can. So thank you for giving us the leadership, Engineer Abdullah Bukar, Chairman of the BOT PEEF. On this note, we normally also announce the next steps. We're going to put our action plan together. Some people call it communicate, but we want to make us actionable and engage the relevant stakeholders in both public and private sector of the economy. And also, we will be next year, looking ahead next year, start our PEEF virtual talk again, which will be quarterly. Again, we take thematic topics that are of interest in terms of impact on the people's life in different sectors, and we focus on them. And towards the end of the year, next year, again, we'll have our 7th PEEF Annual Conference by the will of God. For those who have attended this conference, we will share the conference material, the presentation slides with you, since we have your email addresses. And we hope that this will be of use in terms of engaging issues with an informed background, but also if you are in a position of influence, also do something about some of the resolutions that we have reached today. On this note, thank you all. And if you could just put on your camera so that we can have a gallery view of everybody. Am I communicating so that we can take? Yeah, everybody, please put on your camera. We need this for the archive. Also note that this conference has been recorded on YouTube, so it's available. We're going to edit some aspects, especially at the beginning when we didn't quite start well. Then everything else will be there for you to access later and follow the proceedings if there's anything you have missed. Okay. All right, so I'm waving my hand. Please, could you make it more dynamic? Yeah, so see you in 2024. Thank you. Bye. Bye-bye.
Thank you. God bless you.